invitarme. I want to start out a little bit and just talk about why we need classification systems. And coming from now that I've been in Houston almost 6 years, there's been a history of classifying things in Houston that started mostly with the aorta. So I don't have any conflicts of interest to disclose for this talk. I accept that I am bivascular. I do open and endo. So why do we classify anything? So the reason you classify things is to order them into groups, because it differentiates characteristics of that group and makes it easier to remember, but it also makes things easier to understand and to predict behavior and outcome. So I'm going to run through really quickly some classification systems that are used in nature, an interesting one that was used for clouds, and then the aortic dissection ones that were started with Diabetico and Stanford in the United States, and then get into why we have a new classification system for chronic limb-threatening ischemia, and specifically for the diabetic foot. So Linnaeus is interesting. He was a Swedish botanist, and at that time, people could get educated and pretty much read every book that was in the world. And he, interestingly enough, suffered strokes in 1773, 1776, 1777, almost for sure from left carotid occlusive disease, because he had hemiparesis on the right, the contralateral side, and aphasia. But I started thinking about this maybe 10 years ago about why we classify things. So this is the Linnaean structure of nature. So he took all of nature and broke it up into components and grouped things together. And this was really before we had genetics. So the first thing you think of when you see this is it's unbelievably complex. Nobody could possibly use it. But it turned out, except for some minor adjustments, we still use it today. So sometimes when you're describing something as complicated as nature, your system has to be complicated. And he created a garden where he was from in Sweden, and he had a garden clock, and it had the flowers that would open at different times of the day, so they would reflect the time of the clock. So he was a very organized person. And I kind of like this because it's a Venn diagram, which will line up with some of the Wi-Fi parts I'm going to give. Now, Luke Howard, you may not have heard about. So he was a Quaker. He was born in London. He was a chemist primarily and a pharmacist, but he was an amateur meteorologist. And every day he would go out and analyze the clouds and try to describe them and put them into groups. And he did this comprehensive recording of the weather in London over a 3-year period. And he noticed that clouds were subject to certain distinct modifications. And he thought that these were all caused by natural circumstances. So he began to describe them, notice the patterns and stuff. And so the names that we use for clouds now, like cumulus and stratus and cirrus, alto cumulus, all from Latin, but these are the same words we use today. And once we understood the science better, we understand why the clouds form that way. But this was all done solely by observation. So this gets us up to vascular surgery. So this is an old paper from 1964 from Michael Diabetico and Cooley when they still talk to each other, Dr. Crawford. And they basically broke down dissections of the aorta. And at that time, the first dissection repair took place in 1954. So by 1964, Diabetico's group had done 140 cases over a 9-year period, which at that time was the largest experience in the world. But he classified them basically by location and by the type of surgery that would be required to fix them. So basically you had type 1, 2, 3A, and 3B. And then that persisted for many years, actually. There were only Stanford and Diabetico classifications until recently. Now that we understand entry chairs better and some of the mechanics of it, we realize that this old classification system doesn't serve us well when we have new options like endovascular therapy. So this paper just came out this year, actually. It was a whole new classification system for aortic dissections, for type B specifically. And this is based on things that we think impact therapy and impact outcome. So you can see how detailed this is compared to the Diabetico classification, which was basically 1, 2, and 3A and 3B. Now we have 3 types based on the entry tear, 12 types based on proximal extent, and or 13 types based on distal extent. So this has become much more complicated now that we have a better understanding of the disease. So let's get to chronic limb-threatening ischemia. So my German is better than my Spanish. My mom was born in Austria, and I learned German as a child. Trying to learn Spanish as an adult has proven difficult. But this was the 1954 classification from Fontan that is still used to some extent today in Europe. And basically, they had a primitive normal saline study that they could do to assess perfusion on people. But this was back in the 50s when most patients were pure atherosclerotic ischemia patients and were cigarette smokers and relatively few diabetics. So for them, stage 1 were patients who had no clinical symptoms, but they had arterial occlusive disease. Stage 2 was patients who had no symptoms at rest, but when they walked, they got claudication. Stage 3 was rest pain, so ischemic rest pain. So they got pain when their foot was elevated at night. And then stage 4 was gangrene, and they broke gangrene down into limited gangrene and extensive gangrene without any great description. And interestingly, in German, this word Brand can also mean fire, and it can also mean thirsty. So if you think about it, this is a pure ischemia model of limb ischemia. And back in the 1950s, 60s, 70s, even 80s, this was fine for most of the patients we saw. You got a progressively thirstier limb until it became so thirsty that what do you do if you're really thirsty? You get them a drink. So this was a pretty simple problem for the first half of my career, is you sorted out these severe ischemic patients and you found a way to get more blood to the foot. Seemed like a simple problem. Now, this is also important. So this was a definition that came up in 1982 called critical limb ischemia. And this happened at a symposium that was held in the UK in London. And there's some famous people on here. Dr. Eastcott performed one of the first carotid endarterectomies. He actually did a transposition. Dr. Rutherford, you know, from the Rutherford classification. Andrew Nicolaides, who's famous for ultrasound and venous disease. Dr. Charlesworth, Dr. Bell, Peter Bell. But anyway, they sat around and said, well, we want to come up with a definition of a term for which the limb is so ischemic that it's likely to need something in order not to have it lost. So I'll get back to the definition of that in a minute, but that was a one-page document. And that was a fairly simple definition. Then you got in the 80s and 90s into the Rutherford classification. And they basically took the Fontan classification. These are very similar. So you have asymptomatic patients. Claudication got broken up into mild, moderate, and severe, ischemic rest pain. Then they broke tissue loss up into minor tissue loss and then major tissue loss, which they actually defined as extending above the transmetatarsal level, so that if you couldn't get a transmetatarsal amputation to heal, so you either had to do a below knee amputation or something like a Chopard or Liz Frank. But in addition to these clinical descriptors, they mandated that you objectively measured the circulation. So for these patients that had mostly pure ischemia and weren't diabetic, ankle pressures and toe pressures were fine. So here's the problem. As I went into practice for many years, I started to notice that my patients were different. So the patients I saw early in my career, they've had pretty obvious ischemia. And no matter how you measured it, it was pretty severe. And the task was just to find a way to get blood from the top of the leg somewhere to the bottom of the leg that ran to the foot. But then we started seeing more patients. This was back in the 90s. And this was when I worked with Dennis Bandick. So patient came in with a bad foot infection, had open guillotine of all the toes except this one, so just for damage control. And you can see after about a week, the wound's clean, but there's pale tissue. There's not much granulation tissue, but the infection's been controlled. So now the infection's out of the way, but the foot's still thirsty. So this is a bypass to the plantar bifurcation. Here's the medial and lateral plantar arteries. I did a limited endarterectomy of this site, plugged the vein into that. You can see how good the small vessels are in this foot. There's no small vessel disease in this patient. This was back in the 90s. And then we did a transmet and a skin graft, healed completely. So that was a pure ischemia patient, but complicated by infection. So let's go back to that critical limb ischemia definition from 1982. So they recognized two things. One, that if you had ischemic rest pain, you had to have pretty poor circulation for that to be really from ischemia. So they lined that up with an ankle pressure less than 40 or a toe pressure less than 30. They also realized that once you had a break in the skin, so a break in the integument, it might take more circulation than that to heal a wound. So if you had a wound on the foot with an ankle pressure less than 60, they felt like that would be critical limb ischemia. And by critical, they meant that something was likely to need to be done or the limb would be lost. But what people forgot is there are these two statements in this article that it was generally agreed that diabetic patients, because they have neuropathy, ischemia, and sepsis or infection, should be excluded. They were never meant to be included in this definition of critical limb ischemia. So at a time when most of our patients were tobacco smokers and most of them didn't have diabetes and neuropathy, they didn't often come in with an infection, these definitions, Fontana and Rutherford, work fine. But what happened? So I started to notice this in the 90s when I was in Arizona. This is an interesting statistic. So diabetes is a global epidemic. Almost every country that's listening to this talk, diabetes is increasing in their country. So somewhere in the world, diabetes is diagnosed once every 17 seconds. And somewhere in the world, every 20 seconds, somebody's losing a leg from diabetes. So about the same rate as new incidence diabetes, a leg is coming off. So it's clearly a problem. And the problem with diabetes and amputations is it's not just a pure ischemia model. So these are all patients I've taken care of over the last 30 years. This is a small neuroischemic ulcer. This is early wet gangrene. This is a non-healing lateral foot ulcer. Then you have more extensive tissue loss here and here. This was a patient who had a failed bypass that got infected, and their limb was actually saved by endovascular therapy. And this is the only patient on the screen now that didn't salvage their leg. So he had just had a heart attack, was in the hospital, got extensive heel necrosis, Achilles necrosis, had an ejection fraction of 20%, and we elected to do an amputation on him because we didn't think he'd survive anything else. But all the rest of these patients from here up all fall under Rutherford 5. But what you might have to do to heal this foot is probably different than trying to heal this foot. So that got us thinking, well, let's look at perfusion. So if you look at ankle pressure in yellow, toe pressure in red, or TCPO2 in blue, they all form these sigmoid curves. So the pure neuropathic patient, which I saw a lot of early in my practice, so a diabetic patient would come in with an ulcer or a foot infection, their foot would be warm, they would have hair on the foot, they would have a palpable foot pulse. No matter which one of these you measured, it was normal. They don't need a vascular surgeon. They need offloading, they need infection control if they have it, they might need debridement. And then there are patients that have severe ischemia where no matter how you measure it, it's poor. And if they have anything but a trivial wound, they're probably going to require revascularization. But what about all these patients in the middle here? Does every single one of these patients that comes in with diabetes and a foot ulcer need urgent angiography and treat whatever lesion you see? That seemed illogical to me. So, and for some patients, for example, this patient with this tiny foot ulcer and a foot deformity, let's say they were here on the curve, if we could do something to push them up the curve a little bit, but not get them quite all the way up here, would that be enough? So the problem was that Fontana and Rutherford were pure ischemia models. They really weren't intended to be applied to diabetics, nor was the concept of critical limb ischemia meant to be applied to diabetic. And then the other thing that changed was, at least early in my training, most patients we saw had pure neuropathy. The vast majority of patients I saw in my diabetic foot clinic back in the Air Force were just treated with offloading and drainage of their foot, and only a small number seemed to require revascularization. But the reason we took them all on our service is we didn't want to miss those patients that would benefit from revascularization. Well, over the last decade, when you start studying these patients, it seems like the disease has shifted. So about 2/3 of diabetics have neuroischemia. So they have neuropathy, which is often the loss of protective sensation is often what leads to the foot ulcer. But then, depending on how big the ulcer is, where it is on the foot, whether it gets infected or not, if there's some component of ischemia, it might contribute to limb loss. Then the second thing we started thinking about was what's wrong with Fontana and Rutherford? They don't mention infection. If you treat patients with diabetes and you see all comers in your emergency room or your clinic, you'll see a lot of them have infection, and infection is often what drives amputation. So we had these classification systems that weren't meant to be applied to diabetics, and they also excluded infection, which we know is a big driver of amputation. So this was another study. This was Eurodial. So they took a simplistic view of PAD. And this was back before we saw so many patients with incompressible vessels, but they basically defined PAD as an ABI less than 0.8. And if you had infection in the foot plus PAD, it tripled your amputation rate compared to a foot ulcer with no infection, or infection only with no PAD, or just an ulcer with no infection. So this combination of ischemia plus infection seems to be important, and yet it's not accounted for at all by Fontana and Rutherford. So this gets to my love of Venn diagrams. So what I wanted to do initially, almost 10 years ago, was put something together that included all these things. So from my perspective, until recently, over the last 10 years or so, everything in vascular has been focused on the anatomy of the patient. And I think that's an important part once you decide they need treatment, but it's not the whole story. You start out with a patient. So how sick are they? What are their comorbidities? Look at other things, for example, what's their life expectancy? How active are they? Do they have an available vein conduit? So I wanted to come up with a system that classified the patient, classified the limb, and classified anatomy. So I talked to Tony Sadawi at the time. He was president of the SVS, and he linked me up with Mike Conti, who's at UCSF in California now, because the Global Guidelines Committee was just starting. And we decided to tackle just this one piece, the limb status. And so what wound ischemia and foot infection, or Wi-Fi, is meant to be is just like TNM for cancer, right? So you wouldn't imagine treating a cancer without staging it first. So why would we treat a complex limb problem without staging it first, right? Because the stage has some influence on the outcome and also on its therapy. So then you come to, how do we do this? So we have wounds. What extent are they? How deep are they? We have ischemia. How ischemic is the extremity? And then we have, is there infection present and how severe it is? So this paper was published in 2014. It's been adopted by several societies in Latin America. It's been adopted by the Global Guidelines Committee. It's been adopted in Japan. It's been adopted in Europe. And it actually has turned out to be pretty predictive of several different important outcomes. So what we did was we took those three components and said, well, you could have none or mild. You could have moderate or severe. So it's a pretty simple scale. And by the combination of those factors, you can place the patient into risks categories or stages. So this is much like stages of cancer. So class 1 or stage 1 was meant to be low risk of amputation at 1 year, very low. Class 2 low, class 3 moderate, class 4 high. And then we asked, there were 16 members of the global guideline, or the SVS Lower Extremity Guidelines Committee, and I sent them this thing and said, look, ignore Rutherford and ignore Fontan, and go with me for a minute and pretend that we can do this. So we're going to grade all these wounds from 0 to 3. So a patient with 0 only gets in this system if they have ischemic rest pain. So to be in a CLTI category, they have to have ischemia 3. So theoretically, since there's 4 grades of wound, 4 grades of ischemia, and 4 grades of foot infection, there's 64 possible patient presentations. And so what we asked the consensus people to do from the guidelines committee, so this was by Delphi consensus, is answer the question, what's the risk of limb loss at 1 year for these given combinations? If you treat the patient medically, you're allowed to debride them offloading, but you don't get to do a bypass. This is just the natural history of the condition. So this was meant to predict 1 year amputation risk based on this combination of factors. And you can see that once you get moderate to severe ischemia, especially if you have more than a small wound, especially if you have infection, everyone felt the amputation risk was quite high. So the patients in this category fit the hemodynamic definition of what used to be called critical limb ischemia, but these patients have more moderate degrees of ischemia. So what we thought would happen was that if you stage patients this way, the amputation risk over 1 year in patients, the natural history of the condition would be something like this. So what actually happened? This was a study we did in Arizona. So this study was the second study that came out that looked at Wi-Fi. And this was our SALSA clinic in San Antonio, in Tucson, Southern Arizona Limb Salvage Alliance. And these were consecutive patients that had to go to the operating room for a limb salvage procedure, either a debridement, a minor amputation, or revascularization. And these are the outcomes of limb salvage in blue and major amputation in red. And you can see we had no amputations in stage 1 and 2, very low rate in stage 3, and most of the amputations were in stage 4 patients. If you look at amputation and 1 year amputation-free survival, in the stage 4 patients, we still saved 60% of the limbs at 1 year, but not all of them. And a lot of these patients had renal failure. Then this is one of the largest studies. This is from Darling's group in Boston. And this is interesting. If you look at the whole grid, look out here in this group of patients that have severe ischemia, a large wound, often a heel wound, and infection. In this group, 75 to 100% of their patients lost their limb, even if they were revascularized. So the point of this is that you can probably start having a conversation with some patient. If they're in this category and they're a very frail patient with lots of medical comorbidities and they're at high risk for intervention, they might be better served with primary amputation. So we're not advocating that, and it needs to be verified. But this group, you can see the limb loss rates are really high in this far right part of the curve. So we put this together about 2 years ago. These were the first 8 or 10 studies that staged patients by Wi-Fi and looked at 1-year amputation rates. So this group was patients that were only revascularized from the South Carolina group. This was our Arizona study. Darling was from Boston. Causey was San Francisco. Baropoulos, these were non-diabetic patients from Germany. Ward was all comers to a wound clinic at USC in California for indigent patients. This was another Darling paper on not just endo, but all comers. This was an all comers clinic to Massachusetts, and Mathiadoukas is from the Hopkins group. But basically, if you look at the mean and median 1-year amputation risks, there's a huge difference between stage 1 and stage 4, even with revascularization. Stage 2 and stage 3 overlap a little bit, but if you do a separate curve, which I didn't show here, but looks at wound healing time, stage 2 and 3 are different. So wound healing time from initial treatment to revascularization to final wound healing is delayed in stage 2 versus 1 and 3 versus 2 and 4 versus 3. So it does predict wound healing time as well as limb loss. This was published last year. This was an independent meta-analysis done by a Dutch group, and they took 12 studies that met fairly rigid criteria that had almost 2,700 patients in it. And they looked at the Wi-Fi classification, and the 1-year major amputation rate was 0% in stage 1, 8% in stage 2, 11% in stage 3, and 38% in stage 4. So if you recall, these stage 4 patients hemodynamically meet the old CLI definition. So this can partly explain why when you look at large series of patients and you don't classify them, it's hard to tell why the limb salvage rate would be better or the same for endovascular therapy, even though we know in many cases it's not as durable. And the reason is probably this: in some of these patients, you don't need to have a procedure that lasts forever. They need good wound care and maybe a bump in their circulation until they heal. Now, these are 2 important studies. So on the left here, this is from Japan. And in Japan, first of all, they have a lot of renal failure patients, and they have a lot of diabetes. And a lot of the endovascular therapy in Japan is done by cardiologists. So this group of CLTI patients was stratified by Wi-Fi, and all they got was endovascular therapy. They never got a bypass. So blue is wound healing rate, green is limb salvage rate, and red is repeat endovascular therapy rate. So what do you see? In the class stage 1 patients, they had 100% wound healing rate and 100% limb salvage. Stage 2, they only had 82% wound healing rate, but they saved 96% of the limbs, but they had to do repeat endo in more than a quarter of patients. And then look at stage 4. So in stage 4 patients, half of them had repeat endovascular therapy. The limb salvage rate was 80%, but in those patients who had salvaged limbs at 1 year, they still had almost 55% who hadn't healed their wounds. So contrast this is a San Francisco study from Mike Conti, and these aren't randomized, so it's not totally fair, but they were all clinical stage 4 patients. These patients had bypass first, and these patients had endovascular therapy, and there was a huge difference in limb salvage in the group that underwent bypass. So if this can be validated, it suggests that if the patient will tolerate it and they have a vein conduit and they're clinical stage 4, that might be the group that gets bypassed first. For stage 1, many of these can be managed without revascularization, just wound care. And stage 2 and stage 3, endo works pretty well, although the reintervention rate is higher than you would expect from a bypass. Now, another point to make, if you want to compare Wi-Fi to TNM, tumor nodes metastases, Wi-Fi wound ischemia foot infection, this is from the Alabama group. So what do you do when you treat a cancer? They usually, if they're going to get multimodality therapy, and you can use that analogy with the limb, right? They need revascularization. Maybe they need drainage of infection first. Then after revascularization, they need further debridement. And then ultimately, you're going to close the wound. So what do you do when you do cancer therapy for patients? You start the first course of therapy, and before you embark on another course of that same therapy or switch to something else, you restage the patient. So in cancer, if the tumor is responding to that therapy, you might continue the whole course of therapy. If the tumor is not responding, you might choose an alternative approach. So what they did, and this is from the Alabama group, They looked at the 1 month wound, ischemia, and foot infection grades, and those had a much higher correlation with limb loss than the baseline grades. So that makes sense. If you've addressed the infection, you've corrected the ischemia, your Wi-Fi stage at 1 month should be better than it was at baseline. If it's not, the two most common reasons are either your ischemia has not been totally corrected, or the procedure you did has already failed, or the patient still has undrained foot infection. So we think that patients at 4 to 6 weeks after their initial treatment should get restaged to make sure you're really on the right path. This I'm going to skip over because it's a little complicated, but what we did, there was a second part of the Wi-Fi curve, which I didn't show you, was predicted benefit of revascularization. So we predicted that patients with larger wounds or with moderate wounds that were complicated by infection that had moderate ischemia would benefit the most from revascularization, and that patients with small wounds with mild ischemia probably wouldn't need it. So we took data from 10 different centers. Most of these were in the US, but I think we had one Japanese group that contributed, and these were all patients who were revascularized. So it was 1,600 limbs. And we looked at this predicted benefit of revascularization. And what we found was the wound, ischemia, and infection scores all had independent predictive values, and that patients that did the best had severe ischemia with small to medium wounds. Patients didn't do so well if they had severe foot infection and large wounds and severe ischemia. And they didn't seem to benefit much with small degrees of ischemia and small wounds, because many of those heal anyway. So in conclusion, I would state that wound ischemia foot infection is logical. It gives you a way to stage these patients. It does predict outcomes. So it predicts a couple of things. It predicts wound healing time. It predicts how many resources you're going to have to use. So there was a slide I didn't include from the UMass group that looked at length of hospital stay and the requirement for plastic surgical procedures to control the foot and for repeat procedures to heal the foot. And they correlated very highly with Wi-Fi stage. And so the point of this, if you're going to try to compare outcomes of different therapies, you have to stage the patient up front. And the stages aren't meant to be set in stone. They can be modified. They don't mandate therapy. For example, if we get technology that reduces intimal hyperplasia, some patients that right now do better with bypass might do equally well with endovascular therapy. Now, there is an app. The new one, we just had to redo it. So the SVS company that helped us with this app before, it's free. It's called the Interactive Practice Guidelines, and you can use it for Android or Apple. The new version should be out shortly. We just revised it. So my final couple of slides, all of this led to this big group that was put together with many South Americans and Latin Americans were included. There were 58 authors on this. Alberto Munoz was involved. Juan Esteban Paolini from Argentina was involved. I can't find all the names I want here, but there were 58 authors from around the world and put this document together. And we met in Lyon, France a couple of years ago, pre-COVID, to present these guidelines on the management of chronic limb-threatening ischemia. So the key terms of that, I'm not going to be able to cover that whole document in this short talk, is the change in terminology from CLI to CLTI. And why is that important? CLTI means that every patient with a diabetic foot ulcer needs to have their perfusion assessed and have it placed upon a spectrum from minimal ischemia to mild ischemia to moderate ischemia to severe ischemia. So it's no longer acceptable to not look for ischemia in these patients. It also recognizes a spectrum. It's not something where there's one critical value of perfusion above which everything heals and below which things don't heal. So it allows you actually to revascularize some patients that don't meet the traditional definition of critical limb ischemia. It's based upon Wi-Fi. So you stage the ischemia, you stage the wound, you stage foot infection. Then you develop a plan. So plan stands for the patient. And there was a paper that was published in this same, it was published both in the SVS and the European Journal, that was based on VQI data that looks at patient risk of morbidity and mortality from open surgery, both short-term and 1 year. So you classify the patient. So a high-risk patient for operative mortality and 2-year mortality would probably be better served with endo. If they have lower predicted mortality risk and they have available conduit and they have good 2-year survival, at least what we have with the Basel trial is they might do better with bypass. You classify the limb, And then finally, you classify the anatomy. And the anatomy classification is really complicated. That would be a whole talk in itself. But basically, it's based on two relatively new concepts. So one is target artery path. So it assumes you've corrected the inflow to the common femoral level. And then you look at the angiogram and try to predict if you're looking for angiosome-based revascularization, or if you don't need that for that particular case, what's the target artery path you're going to choose to get flow from the groin to the foot. And then if you think about long-term outcomes, if you're treating SFA disease plus popliteal disease plus tibial disease, each one of those treatment segments has a predicted failure rate, right? So a short focal stenosis in the SFA might have good long-term durability. But if you're treating a patient with a long SFA lesion, a popliteal CTO, and a tibial occlusion that's more than 4 centimeters, if you start looking at the limb-based patency for that entire reconstruction with endo, it's probably pretty low. So I want to conclude, and I hope I leave time for questions. I think the most important message I want to leave you with is it takes a team to take care of these patients. It's not one person. So this is our group. We have now 4 vascular surgeons at St. Luke's, 2 full-time podiatrists, Dr. Lipo and Dr. Ross. We call our program the Save the Extremity Program STEP, and we have nurses and techs that help us with all these patients. But if you really want to have an impact on this disease, you need to work as a team. And the best team, I think, is composed of people that understand the foot anatomy and people that understand how to reperfuse the foot when it's needed. So that's where I live now. This is our new hospital is being built right here. This is downtown Houston in the background. So the medical center is here. It's actually separate from downtown Houston. And when you fly over, it looks like 2 separate cities. But if the medical center were a city, it would have the 8th largest economy in the country. It's a crazy place. But they're building a new hospital here, and we're eventually our current hospital is right here. So anyway, thank you for your time, and I very much appreciate the invitation.
Dr. Mills, I found that absolutely fascinating. Having left arterial surgery in 1999, I see that we've gone a long way. But my first question to you would be, looking at class 4, what patients other than the ones with comorbid would you not want to revascularize? I mean, I looked at your meta-analysis where it was like 25% amputation rate.
Yeah, I think those are the patients you need to really sit and talk to. So it's this planned decisions. So we wrote one paper. It was based on 2 anecdotes. So we had a younger patient who was pretty fit with a pretty complex foot wound, and we had an older, frail patient who was retired and just wanted to keep his limb and hobble around the house and didn't have to work anymore. And the younger patient we had a long talk with, and we did a primary below-knee amputation and immediate prosthesis fitting on, and he was back to work in less than 2 months. And the older patient took about 6 months to heal, and he was able to walk around his house, and he didn't lose his limb. So I think there's 2 things that come into mind there, but I think you need to tell the patient up front. You just can't tell them, well, we're going to drain the infection and revascularize your foot and it's going to heal. For those patients, it's a 3 to 6 month and sometimes a 1 year long series of procedures that are required. So if you don't tell the patient that up front, they're obviously going to say, I want my limb saved. If you tell them, and we've had some patients where the other thing we do is we'll start like we do with cancer. Sometimes you'll start a patient on chemotherapy and say, let's see how you do. And if they start to have complications of chemotherapy and they say, look, I can't do this anymore, I would rather live whatever time I have left and not be sick all the time. Same thing happens with the limb. So you could start on the route to revascularization. And I tell patients that's sometimes an option, and then reassess it 4 to 6 weeks and see if you're really making progress. And then have the patient help you decide, do they want to keep going or not? Because some of that's a personal decision. It's not all based on anatomy or an infection or how big the wound is.
Thank you. Professor Victoria, do you have any comments or questions?
Nice presentation, Dr. Mills. I have a question. Once you decide that the patient needs a revascularization, what is the consideration of you opt with by the endovascular procedure or surgery procedure
yeah, it depends on the patient. So I look at their overall functional status, and then I also look at what they have for available vein conduit. So we have a lot of renal failure patients where we can't use their arms because they have those for access. So if they've had their leg vein used up for cardiac bypass or they've failed a bypass, we get a lot of patients that are referred with failed bypasses. In general, I prefer an endo approach first to a PTFE graft to a real distal vessel, because I don't think you lose much. And in a lot of these patients, you can get it to stay open long enough to heal. But I think, unfortunately, it becomes too easy to do endo, and the better you get at it, the more likely you are to try it. And I think some of these patients, if you believe that data I showed you from Japan, and some of our own data, will look at patients that have 6 and 7 procedures over a year to keep their long segment endo open. I think that's excessive. So I think my personal belief is look at them up front. And if they really have long segment multi-level disease and they have a conduit and they have more than a trivial foot wound, they probably should have a bypass first.
Thank you.
Thank you.
Professor Alberti, comment, question? Dr. Alberti?
Doctor Alberti, ¿tiene alguna pregunta para el doctor Mills?
Very nice presentation by Dr. Mills. The Wi-Fi classification is a really big advance over the previous concepts we have. I haven't applied yet in my center because of sheer complexity. Do you think we could have the same predictive capacity by using less factors to compute the outcome?
Maybe, but if you think about it, the app makes it easier. The other way to do Wi-Fi, so the Boston group reported it, and I just reviewed a paper for another journal. They took each individual grade and added them up. That was my original plan. If you think about the coronary disease system, they have a scoring system that's a total score. That probably has validity also, but I think you have to stratify them some way, and the app helps a lot. But if you don't break it into the components, you're missing information. And I think the big thing that gets overlooked a lot is infection. Because infection, if you have bad foot infection, that has to go first. But I think the app does make it easier. Unfortunately, it is more complicated. If you look at our thoracic aortic system now, it's much more complicated than it was before because we understand the disease better. And the other thing we've seen is that if you look at the global guidelines, for example, on their GLASS system for anatomy scoring, it's very weak on the foot. And I'm sure you see these patients where you angiogram them and there's not much wrong with their circulation until you get to the foot. And then they have almost nothing in the foot. So it's called desert foot by some people. And that's a disease pattern I didn't see much of 20 years ago. Now it's fairly common. So that's led to newer procedures. So Lengua, who was from Peru, I think originally, described deep vein arterialization. There's now percutaneous ways to do that. And we've done about 50 of those now. So I think the disease pattern's different. And I think the patients are more complicated than they used to be. So I think if your scoring system's too simplistic, it's not going to be very predictive.
Thank you. I have one really interesting panelist, and his name is Dr. Sapoznik. He's an orthopedist. I would really like to see if he would comment on this classification. If you could unmute yourself, that would be great. I know he was here. Well, we'll move on, and when he comes back, Dr. Navas, do you have any comments or questions?
Dr. Hugo Navas.
Sí.
Yes. Congratulations, Dr. Olmais, for such outstanding presentation. Yes, my question is, how is the approach in the morbid obese patients in order to planning a revascularization procedure?
Yeah, so the issues with them are vein harvest can be a problem with them. And the other issue is percutaneous access can be a problem also. So those are sometimes patients that will access distally. So there are people that actually go pedal first on many cases. I usually try first from the top. But if I can't get through very quickly, I'll quickly convert and go from both the top and the bottom. Sometimes it's much easier to cross lesions from below. Bypassing those patients, I try to stay out of the groin. So if they don't have common femoral disease, I try to make my incision over the SFA or something if I have to do a bypass. And I try to do skip incisions if I have to harvest vein. And I try to map their vein first, so I know exactly where it is, so I don't have any flaps when I make my vein harvest. But in morbidly obese people, we'll often try endo first either from an SFA access or from pedal access.
Thank you.
Thank
But
you.
obesity is a big problem. It complicates their wound healing.
Everything.
Yeah, it complicates. No matter how you try to approach them, it doesn't make life easier.
Claudia Sapoznik, I really would like your comment if you could unmute yourself on this classification. Victoria, maybe Dr. Victoria. Oh, there he is. Good.
Yes. Doctor, doctor Juan Manuel López, ¿está por allí? ¿Alguna pregunta del panel? Doctor.
I have another question.
Okay.
Okay. Dr. Alberto, go ahead.
Do you think there is a place for a specialist leg interventionist or special or vascular surgeons specialized in limb salvage due to the increased complexity of the cases we are seeing? And maybe our specialty is dividing. I think that the vascular skills and even the knowledge that you have to do aorta is not the same that you have to do the leg.
Yeah, you know, we had a conversation. I used to be on the American Board of Surgery. We talked about this maybe 10 years ago. Would vascular surgery become like orthopedic surgery, where you have hand surgeons, or ophthalmology, where you have people that specialize in different parts of the eye? And I think there's some truth to that. If you really want to be really, really good at this, you can't just do it occasionally. So for me, if I want to be good at leg endo and also want to maintain my open bypass skill set, it's hard for me to also be the best fenestrated person in the group. So what we do is all of us can handle most of the common emergencies that come up. But on some of these special cases, we'll double scrub, or we'll have one person who has a bigger interest in one area. I don't want vascular to become so specialized you're just a left leg doctor and somebody else is only. But for complex disease, you probably see this in every country. Like Houston's been an aortic center for 50 years. Until we came, there wasn't a lot of interest in legs, so that's kind of how we developed our practice. But we like to do aortic surgery too. But we have certain people in our group that are more interested in that. So when I have a TVAR, I usually have one of my partners with me. Just because I have one guy that loves to do the measurements and do the 3D planning. I hate that. I like actually being there on the case and watching the wires and trying to figure out where you're supposed to be, but I don't like sitting there on the computer for an hour drawing lines and figuring out where the fenestrations are. But that's a really important part of the case. So long story short, I think you're correct. I think increasingly, especially for the aorta and probably for lower extremity, that there will be super specialists.
Well,
and in Europe, most of the limb salvage centers, that's all they do. You know, they often have a diabetologist who trained to do foot surgery, and they have a really good either cardiologist or angiologist or interventional radiologist who's skilled with endo, and they have traditional vascular surgeons who are skilled with open and hybrid, and they look at each patient and do what's right. I think that's the way things are going. And certainly for complex aortic care, that's going to have to be.
Thank you, Dr. Mills. I really appreciate your time and efforts and what you've done in terms of classification, and congratulations on that. And hopefully you'll find subsets. We're going to move on now to Dr. Hingorani. Neil Hingorani is a friend, colleague, assistant professor of surgery and great vascular surgeon from New York University. Dr. Hingorani has a huge experience dealing with arterial disease, and today we'll be talking about diabetic foot management practice guidelines. Guías de práctica de manejo de pie diabética. Anil?
Thank you. Thank you for the introduction. So again, we're going to be looking over these guidelines that we'd put out before, looking at the management of the diabetic foot. And what's peculiar about this set of guidelines is that it was put out by 3 different societies working together: the American Podiatric Medical Association, the SVS, and the Society for Vascular Medicine. Again, it helps highlight the complexity of these patients, but also the sorry, this is not advancing. Okay, so I have no conflicts to disclose. So again, looking over what Dr. Mills had said, diabetes is a worldwide epidemic. There are 463 million diabetics estimated in the world today, and this is expected to increase to 700 million patients by 2045. The lifetime risk in a diabetic for a diabetic foot ulcer is about 15 to 20%. So we're seeing a lot of diabetic foot ulcers, and that's increasing worldwide as diabetes is increasing. Diabetic foot ulcers, of course, have adverse sequelae with high cost and decreased quality of life. We had 5 areas that we wanted to focus on for these set of guidelines: prevention of the diabetic foot ulceration, offloading once you have the diabetic foot ulcer, wound care for the diabetic foot ulcers, diagnosis for diabetic foot osteomyelitis, which is often the cause of these amputations, and the nexus between peripheral arterial disease and the diabetic foot ulcer. We use a standard grading technique to look at these recommendations for these guidelines. And again, grade 1 and 2 was grade 1 was that they clearly, these guidelines would clearly benefit and outweigh the risks. And the level of evidence were level A, B, and C. Again, very standard grading for recommendations. Starting off with the basics, we suggested that patients who have diabetes undergo an annual interval foot inspection by a physician or an advanced care practitioner once a year, routinely. If they have a problem or not, they get an exam. However, in certain patients, the follow-up should probably be a little more frequent. For example, if the patients have peripheral neuropathy, they should probably be examined semi-annually. If they have neuropathy with foot deformity or peripheral arterial disease, which many of our patients that we see in the vascular office do, they need to be followed quarterly. And if they've had a previous ulceration or amputation, then they need to be seen even more frequently, either monthly or quarterly. We also suggested routinely that these patients undergo exam for diabetic neuropathy, specifically using the Sens-Weinstein test. We also suggested that patients routinely be educated in terms of their patients themselves and their families about preventative foot care. We suggested against the use of routine specialized therapeutic footwear in the average risk diabetic patient. However, for patients who are high risk diabetic patients, including those with significant neuropathy, foot deformities, or prior amputation, then custom therapeutic footwear seemed to be in order. And that was a 1B recommendation. So there's fairly good evidence supporting that. We also suggested adequate glycemic control with a hemoglobin A1C less than 7%, being important to help reduce the incidence of diabetic foot ulcers and infections and the subsequent risk of amputation. We suggested against prophylactic arterial revascularization, and this is aimed at some practitioners who are doing these procedures in patients who may be asymptomatic. One of the highest level of recommendations that we had based upon randomized prospective data was that of patients with plantar diabetic foot wounds, we recommended offloading using the total contact cast. Why is this so important? Well, first, we have randomized prospective data comparing this to other types of offloading, and the results were excellent. And more importantly, it's one of the least used types of care for these types of patients with the maximum benefit. In patients with diabetic foot ulcers who require frequent dressing changes, however, a removable cast walker or an alternative to a total contact cast may be used. We also suggested against using postoperative shoes or standard customary footwear for offloading diabetic foot ulcers. In patients with non-plantar wounds, we recommended any modality that relieves the pressure, be it a surgical sandal or a standard post-op shoe, whatever you need to get the pressure off. For high-risk patients with a healed diabetic foot ulcer, including those with a prior diabetic foot ulcer or partial toe amputation or Charcot foot, then we suggested specialized therapeutic footwear with pressure-relieving insoles to try to prevent new ulcers or recurrent foot ulcers in these patients. Okay, moving on to diagnosis of diabetic foot osteomyelitis. The easiest way to diagnose this is on physical exam. You take a sterile Q-tip, probe the wound, and if the bone is exposed on exam, you have osteomyelitis if the patient's a diabetic. Simple, cost-effective, and very sensitive. In patients who present with a new diabetic foot infection, serial plane radiographs can be very helpful to diagnose the problem with diabetic foot infections, as well as looking for soft tissue gas and radiopaque foreign bodies. However, if that doesn't work, then the next study of choice would be an MRI. That's based upon prior data showing the best accuracy, sensitivity, and specificity for the MRI looking for diabetic foot osteomyelitis. However, what do you do in those patients who have a pacemaker, or they're claustrophobic, or you can't get an MRI for one reason or another? Well, then we suggest a leukocyte or antigranulocyte scan, preferably combined with a bone scan. After you've made the diagnosis, what do? We suggest that you do a combined, if you're going to be debriding the wound, debriding the osteomyelitis, you need to do both bone culture and histology to diagnose and help guide treatment. However, let's say there's a patient that can't have the whole bone debrided. You can't take out the entire bone because it's in the midfoot or it's in the entire calcaneus. When at least, if you're trying to salvage the foot, you at least need to do a bone biopsy to help guide therapy. For wound care for these diabetic foot ulcers, we suggest that the wound be measured with frequent intervals consisting with 1 to 4 week intervals with serial measurements. Now, unfortunately, the data supporting that is somewhat weak, but we did feel very strongly that these patients should have serial measurements be taken. And if the patients have a diabetic foot wound, initial sharp debridement of all the necrotic infected tissue should be the first step, especially in cases with involving gas, abscess, or necrotizing fasciitis. So what do you do with the wound itself? We suggest a moist wound bed and dressings that control the exudate and avoid maceration of the surrounding intact skin is ideal. How do you obtain that, though? Especially if standard wound care is not working. Well, first you need to debride all the devitalized necrotic tissue and the surrounding callus from the diabetic foot ulcerations and reevaluate it at 1 to 4 week intervals for more tissue that needs to be debrided. Given the lack of clear evidence supporting one type of debridement over another type of debridement, we suggested initial sharp debridement. However, thereafter, you need to base your choice based upon the clinical context, what's available in your local environment, supplies, patient tolerance and preference, and cost effectiveness. How do you assess the wounds for adjunctive wound therapies after your initial debridement and subsequent follow-up? Well, basically we said that if the wound is not decreasing in size by 50% wound area reduction at 4 weeks, then you should consider adjunctive wound techniques. However, you do need to reevaluate the wounds, as Dr. Mills said, for vascular status, infection control, and offloading thereafter. So there's a whole host of types of advanced wound care products that are out there. Which ones are better than the others? While their randomized prospective data shows that each one of these may be helpful in certain patients with diabetes, there's very little data comparing each type of wound care. Therefore, we suggested that each one of them may be helpful in certain patients, including negative pressure wound therapy in certain patients. Randomized prospective data from the 1990s has shown that PDGF works in certain patients. It has problems also, but it does help. In addition, recent data has shown living cellular therapy also can help in certain patients with diabetic foot wounds. In addition, acellular human dermis and porcine small intestine submucosal tissue, or SAS, also help certain patients in randomized prospective data, although small studies, for diabetic foot ulcers. If patients fail to respond to conservative therapy, of course, there's data supporting the use of hyperbaric oxygen, and there are guidelines for their use for hyperbaric oxygen in patients with diabetic foot ulcers also. We suggested for evaluation for PAD that patients who have diabetes after the age of 50 have a routine ABI to be screened for peripheral arterial disease. All comers, with or without wounds, with or without a history of PAD. We also suggested that patients who have a prior history of diabetic foot ulcers, an abnormal vascular exam, prior interventions for peripheral arterial disease, or known atherosclerotic risk factors have an annual vascular exam, including ABIs and toe pressures. We also suggested that patients with diabetic foot ulcers have pedal perfusion assessed by ABIs, ankle and pedal Doppler arterial waveforms, and either toe systolic pressures taken or TCPO2, depending on what's available and what you need to assess for these patients. In terms of revascularization, in our data set, we suggested that revascularization can be performed with either surgical or endovascular methods. However, again, patients should be assessed and classified using the Wi-Fi classification. So which ones should you use? Well, we suggested that a clinical judgment and careful interpretation can help guide consideration for wound and the infection and help determine whether endo or open procedures are needed. In a functional patient, again, going back to what Dr. Mills had said, with long segment occlusive disease with a good autologous conduit, bypass seems to be preferable. Now, is that going to change, or are we going to get more data when we have the best CLA data? Possibly, but based upon the best randomized prospective data that we have right now, if you have a patient who has a longevity greater than 2 years, a good conduit, who's functional, with long segment occlusive disease, I do think that a bypass has the best outcomes. And I would actually suggest there may be a benefit in terms of cost also for certain patients, especially with redo interventions with costly endovascular procedures. This is just an overview of the guidelines that we have. You can take a screenshot if you want, or pick it up later on the YouTube. But this basically breaks down the evaluation for patients and reevaluation for patients with diabetic foot ulcers. Thank you for all your attention, and to all the contributors who helped establish these guidelines. But I do hope that they really do help establish the care for our patients worldwide, and with an increasing problem with increasing complexity for diagnosing and treating patients with diabetic foot ulceration.
Thank you. Thank you, Dr. Hingorani. To be a little bit of a curmudgeon, and I often like to do this, and Professor Mills, this goes to you. Having looked at both presentations and having practiced vascular surgery since 1982, I'm not sure that I'm seeing a whole lot of nuances, maybe the word, not nuances. We certainly got better at endo. We're certainly looked at bypass surgery and whether we were doing it in a retrograde fashion or antegrade fashion. We've tried to figure that one out. But what have we really done that is earth-shaking or miraculous that I would feel really comfortable now in 2020 that we haven't done in the past 5 to 10 years? What are we doing with these patients? You need to unmute yourself.
I think we have a better understanding of the disease. It's more complex than we thought. And I think we also understand that you can't fix this without systematic care. So just having a patient come to the hospital and get random care from whoever's on call doesn't work for this problem. So just like cancer centers were established to take care of cancer patients, just like they measured in the US, at least they measure door to cath lab time for people with acute MIs. We have level 1 trauma centers. We have excellent trauma care for people that are acutely injured, but we've never really systematically tried to approach this problem, even though it's really common. So I think we don't have a cure for animal hyperplasia yet. I think endo has gotten better. We certainly can do long segment. If you had told me we could do long segment recanalizations when I was Dr. Porter's fellow, I would have laughed at you. And now I do them. So they have their role. I was just thinking about this today. I did a carotid stent yesterday, and I don't really like carotid stents. I do mostly carotid endarterectomy. But this was a guy that had a radical neck operation with radiation 30 years ago and had a really high grade carotid stenosis. And even TCAR, his neck was just this woody kind of tissue. And he had a normal arch on his CTA. So I put a carotid stent in him and it took 30 minutes. But back when I trained, I would have had to do an open operation and get somebody to help me bring a flap up. So I think endo has been a huge advance. It offers, I think one thing it's done is people are more likely to get referred for revascularization than they used to, because the only option is not a bypass. And I think it does fit in with the volume of patients we have now. If I had to bypass everybody with medium to long segment disease, I would never go home. So it does give you an option for these patients. And I think the most exciting thing really right now is this venous arterialization. It's been talked about for years, and we're starting to figure out that it actually does work and how to do it. So I think that gives an option for the increasingly common patients we see where there aren't good options from what we've learned that you talked about with bypass and endo. So I think a lot of advances, but the biggest thing we need to do is create systems of care with teamwork to take care of these patients, just like we do for heart attacks, just like we do for cancer, just like we do for trauma. And the guidelines are often simple, right? They're just not usually followed. I mean, how many people actually get total contact CAS? Pretty uncommon, right?
I think you're right. I think the team care is what is really championed, and then in the advancement of people going further with endo, I think that's also good. Anil, what do you think?
Agree with what Dr. Mills was saying. I think our understanding is better. One area that I would like to challenge us as a group is that patients with peripheral arterial disease with combination with venous disease can be very, very challenging. And we don't really have a good algorithm, understanding, treatment for these patients that have both, that have venous insufficiency, arterial insufficiency with a foot wound or a calf wound or whatever. How do we get these patients to heal? You're most certainly not going to be doing a vein ablation on this when you might need the greater saphenous vein for an intervention. And some of these patients are very often quite elderly and quite frail. So some of the options for open bypasses are somewhat limited too. So I think we're seeing more and more patients with more complex disease, but I think our understanding is better. I actually have been talking to some of our team about starting an acute limb ischemia team at our hospital for patients with suspected ALI, where like you have a code team for PEs or MIs or whatever. For acute limb ischemia, also time matters so much, because as you wait longer while they're trying to figure out what's going on from the patient's symptomatology, they lose their tissue, they lose their lives. The ischemia reperfusion increases. So besides the chronic limb ischemia, I think we need to develop teams for looking for acute limb ischemia. So a couple of different ideas, a couple of different ways that I think we can go forward and improve the care of our patients.
And thank you very much to Dr. Hingorani and Dr. Mills. I'm going to ask Professor Victoria if he has any further comments or questions, and then we'll move right into the next speaker for lack of time.
Yes, I have a comment. Patients with osteomyelitis are the most difficult to treat, in my opinion, and sometimes we avoid. The criteria that you put for this patient, Dr. Hingorani, however, many times the cost of offering this therapy exceeds that of doing an amputation first. Since many times these patients end in the amputation. What comment does this deserve?
Osteomyelitis, there's osteomyelitis and there's osteomyelitis. If you have a little osteomyelitis of the middle phalanx of the left third toe, that's a very different story rather than having an osteomyelitis of the entire midfoot or the calcaneus or whatnot. So I do think that there is a role for understanding the nexus, as Dr. Mills' talk pointed out, between diabetic foot infections, peripheral arterial disease, and neuroischemia, neuropathic foot. I think because there is such complexity between all three of these, that's one of the reasons why Wi-Fi is so important, to help guide what the expected limb loss is going to be, what may or may not work for this particular patient, and help guide patients and practitioners to what's available and what we might expect based upon what's going on with the patient's foot at that present time. So I think osteomyelitis, unfortunately, we routinely see patients in our neighborhood in South Brooklyn with osteomyelitis. We have some patients that come in every 6 months with a hemoglobin A1C greater than 10. And you take off one toe and they come back later with another toe with more osteomyelitis, and they come back 6 months later with another toe. And the basic problem is the social problems with taking care of patients who are either underinsured, have no insurance, or problems with access to care. I don't think it's necessarily one problem with osteomyelitis. I think it needs to be graded. And I think it also has to be graded in context with all the other issues that we've been talking about for the last hour.
Thank you very much. I'm going to turn the mic over to Victor Canata.
Thanks, Lowell. I just would like to say thanks to all our friends up here, Anil and Joseph, that gave a great lecture to us, and you too, Lowell. Well, just to release both of you, all three, just to have something else. If you have something else, you are ready to go out. But I just, before you finishing, I would just to address two things. One word from Dr. Hingorani and one word also from Dr. Mills for my residents. What do you think about what they have to like a key point for the resident right now? Because you are aware that as a general surgery resident, we hate that kind of trouble. The diabetic foot is just for somebody else who is just taking care, maybe the orthopedic surgeon or somebody else. What are your key points for diabetic foot that just would like to address to the general surgery residents that we have here right now, Anil and also Dr. Mills?
Residents, even if you're not going into vascular surgery, you're going to be seeing these patients. Diabetes affects general surgery, it affects ophthalmology, it affects colorectal surgery, it affects all of the surgery that we do. And it's increasing worldwide. So you need to be familiar with some of the guidelines for taking care of these patients, because it will affect your outcomes in any field in general surgery. You're going to see patients with diabetic foot infections, even if you end up in breast surgery. You're going to see these patients, and you're going to have to know at least the basics for handling these. The Wi-Fi classification, the SVS diabetic foot ulcer guidelines, at least give you some way of starting to take care of these patients. And I think it's important that for the general surgery residents, that you know what those guidelines are and what the basics are for classifying these patients and why it's important.
Yeah, I think that diabetic foot is an amazing way to learn to be a surgeon. So you get to operate, you get to learn how to handle tissue. It's just like infection anywhere else. Like what other part of the body you just take out when it gets infected, right? You drain it. So a lot of these feet can be saved if you bother to learn the anatomy a little bit and you drain the infection, and then you learn how to sort out the ischemia issue, even if you go into vascular surgery. And I know many parts of South America, there aren't podiatrists, or there aren't enough of them. And a lot of general surgeons are forced to take care of this problem. So if you approach it from, I don't want to do it, and you're not going to be doing the best for your patients. So if you're going to be in an area where this is a problem, try to partner up with someone who can do revascularization, maybe learn to do the foot care part. I mean, these are patients that really need you, and saving a limb, I didn't say that in my talk, but if you think about what makes us fundamentally human, why do patients tell you something like, I'd rather die than lose my leg? I've heard that 100 times. It's because being able to walk and be independent is something that makes you fundamentally human. So patients fear that. So if you can help them through these, and we do lose some legs, but you can save a lot of them, it's really rewarding, I think, and it's a good way to learn surgery. It's one of those cases of draining a diabetic foot is the skill set you can teach a junior level surgery resident, and it translates to draining infections elsewhere in the body. Same principle. Damage control, you know, source control, those are important principles.
Okay, thank you very much, Joseph. Thanks, Anil. Thanks, Lowell. I think we keep going. We will just call you in again for a further talks and further news regarding about this amazing stuff that we are already embraced. That is the diabetic foot revascularization, Wi-Fi classification, Wagner, and all the stuff that as a vascular surgeon we love to do in it. Thanks everything. I will just give my final words and give the mic to Lowell to finish that stuff and start with Dr. Victoria, who we just set up the last part of the talk. Thank you very much. And I really give with my heart a big hug to you guys, and we will see each other in the near future. Thank you.
Well, thank you very much, Professor Canata, for the privilege, and to my good friend Anil Hingorani, thank you very much for that informative lecture. And to my new friend, Dr. Mills, thank you very much. Appreciate everything that you've done. And stay tuned for more on diabetic foot and bypasses as I turn the mic over to Dr. Victoria. Thank you, Dr. Victoria.
Thank you to you, Dr. Kapnick. Thank you, Dr. Mills, Dr. Hingorani. Bueno, vamos a continuar con el resto de las charlas. Esperamos ya que el doctor Artino Moraes, creo que ya lo vimos por ahí. El doctor Moraes es especialista en cirugía vascular y endovascular, jefe de residencia en cirugía vascular del Hospital Santa Rita de Maringá, Paraná, un hermoso lugar en donde hemos estado. Sabemos que el doctor habla el español perfectamente, así que no vamos a tener ningún problema. Adelante, doctor Moraes. Su conferencia es Tratamiento de la isquemia crítica de miembro inferior con angioplastía y bypass.
Hola Gerardo, ¿cómo está? Gracias Víctor por la invitación. Yo voy a intentar hablar en español porque es más sencillo para mí, pero vamos a empezar esta charla primero con dos presentaciones hermosas por dos expertos mejores del mundo. Eso que como Víctor consigue esto, yo no lo sé. Víctor está de congratulaciones realmente, porque es muy difícil juntar dos expertos en las mismas charlas. Bueno, yo no tengo conflicto de intereses para esta charla, sí, pero yo voy a empezar con un dato muy interesante. Por ejemplo, la población brasileña tiene 209 millones de habitantes. Más de 65 años, de 9%, 19 millones. Y una estimativa de trombosis arterial de 14,5%, o sea, 2,8 millones de pacientes esperando por nosotros, ¿ok? Y 4% es una estimativa para TVP o para TEVI, para tromboembolismo venoso. Entonces, esto es bueno para los médicos, claro, pero es alarmante para la población. ¿Por qué? Porque esta es una cosa que está aumentando mucho. Entonces, nosotros tenemos que hacer ¿o qué? Nosotros tenemos que hacer profilaxia, ¿ok? Tenemos que evitar que estos pacientes desarrollen estas patologías. Entonces, la primera generación de métodos endovasculares fue la angioplastia transluminal percutánea. Entonces, sabemos que en un primer momento hay una exacerbación del ciclo de lesiones, después una curación, una remodelación negativa y una reestenosis. Isso é que ocorre quando hacemos uma angioplastia. Com o estente no recubierto, temos hasta agora o quê? Fracturas e restenoses interestente. Então, esta primeira generação de tratamento endovascular tem seus problemas e são problemas muito graves. Se han realizado vários estudos, administração local de plactaxel, associado à angioplastia, que também tem uma restenose depois de segmento femoropoplíteo, em las lesiones TASC 2A e B. Então, esse é um desafio terapêutico, principalmente as lesiones calcificadas extensas. Então, nós temos também, por todos os estudos e por nossa experiência, que a cirurgia aberta é uma realidade agora. Então, o que devemos fazer? O que nos mostra a evidência? Eu vou mostrar que a evidência é que a cirurgia aberta nunca esteve tão em voga agora no mundo. Devemos seguir sempre as diretrizes? Com certeza. Mas não devemos olvidar da medicina baseada em la experiência, principalmente em los pacientes diabéticos. Portanto, devemos individualizar a nossos pacientes sempre para hacer para elegir a eles o melhor tratamento. E aún te interessa o custo? Claro, porque vivimos em América Latina, tanto Paraguai quanto os outros países da América do Sul, e principalmente Brasil, nós outros temos um problema enorme de custo. E principalmente é importante para a formação de nossos residentes, que às vezes saem somente sabendo a angioplastia e não sabem como fazer uma revascularização aberta. Então, qual a melhor conduta terapêutica? Aquela que é melhor para os pacientes. A enfermidade arterial obstrutiva poplítea, por exemplo, é frequente em ancianos, fumadores, diabéticos e cardíacos. E tem as peculiaridades, origem embriológico diferente ao sistema ciático femoral. Não se encontra em um compartimento muscular. Sujeito a forças de torção triplano significativas e estresse biomecânico. E a artéria poplítea é totalmente diferente da femoral superficial. Aqui, neste desenho, posso ver as três porções da artéria poplítea, P1, P2 e P3. Então, é uma artéria que, principalmente em los diabéticos, podem estar cerradas. Então, isto afeta negativamente a permeabilidade tanto dos injertos e impõe limitações técnicas a los estentes. Uma revascularização com vena, por exemplo, é muito efetiva. Nós temos uma prioridade em 4 anos de 68% a 80%. Um resgate de membro, um salvamento de membro de 75% a 85%. Já quando uso a prótese de PTFE, a prioridade significativamente é menor, porque tem os defeitos, a trombogenicidade do material, o kinking de próteses em la rodilha, hiperplasia intimal anastomótica, que pode ser tanto proximal quanto distal. E a revascularização quirúrgica é uma estratégia clássica em la enfermedade femoropoplítea, relevante em casos de lesões extensas, como Dr. Mills e Dr. Ingorani falaram há pouco, e estudos de cirurgia aberta versus endovascular são limitadas devido a variações anatômicas, dificuldade para estandarizar métodos, e não há estudos específicos hasta hoje para a artéria poplítea. Porém, a Burana tem um estudo Prevent-3, onde ele arrolou 5.836 bypasses, onde compara a revascularização com prótese de vena arriba e abaixo da rodilha, e a perviedade da vena foi 73, ou 70, quase 74% arriba e 65% debaixo da rodilha, e a prótese 68% arriba e 50% debaixo. São números expressivos, porque temos aí uma grande ventaja para arriba da rodilha e uma perviedade muito baixa para debaixo da rodilha. Isso significa que lá, preferencialmente, hoje, tendremos a fazer uma cirurgia endovascular. O estudo Basel é bypass comparado com vena safena versus angioplastia, grupos arriba e debaixo da rodilha, resultados similares de amputações em los 6 meses, menos complicações pós-operatórias e menores custos para o grupo de cirurgia. E os estentes liberadores de fármacos e os balões não se incluíram neste estudo. Porém, o estudo Basel é o território femoropoplíteo, onde comparou beristent e stent de droga e balão convencional versus balão de droga. O resultado primário, que era o objetivo principal, era uma supervivência de 2 a 5 anos sem amputação maior. A intervenção endovascular, vários estudos em artéria superficial, stents versus balão, beristentes versus stents recubiertos, tendo um follow-up de 3 anos de task C e D, não há diferença entre os tipos de stents. Porém, estes estudos multicêntricos prospectivos mostram de la femoral superficial e poplítea proximal que há uma perviedade superior de beristentes contra balão em 3 anos de follow-up. Isso é um resultado já antigo, pero levamos em consideração esses resultados. Balão com plaquetaxel em território femoral é uma pesquisa muito avançada e temos resultados muito bons com este balão. Grande estudo multicêntrico Impact, por exemplo, em comparação com balão estándar. Ventaja significativa do balão de droga, 82%, contra 52% de perviedade primária. Isso é uma ventaja que é importante para o balão de droga, num segmento de 12 meses. E no território poplíteo distal, continua sendo um desafio para todos os médicos, para todos os cirujanos vasculares e os radiologistas. Por quê? Porque os stents se comportam muito mal com a passagem de la articulação da rodilha. E aqui eu trago, a mim me gusta muito este diapositivo de Burana, porque eu consigo, por exemplo, o que eu uso em oclusão total crônica, Ocelote, Front Runner, Crosser, CTO System. Se eu necessito uma reentrada subintimal, eu posso usar o Pioneer e o Outback. Para as doenças arterioscleróticas bare metal stent e stents recubiertos com droga. Los stents recubiertos, los balões recubiertos com droga, e para aqueles longos segmentos ocluídos e uma placa difusa, eu logro usar uma aterectomia direcional, uma aterectomia orbital, ou que eu tenho usado mais, que é o jetstream rotacional, para ser a aterectomia. E a aterectomia por laser, que para nós outros em Brasília é muito custoso. E com la mejora de los materiales, como los hilos, los guías dedicados para transponer las oclusiones, como tenemos este, que es lo hilo common de Abbott, que es un hilo con la punta de nítido, y que se puede pasar, y ela mantém-se com la memória de sua punta. Temos também o High Torque Connect Point 18. É um guide wiring espetacular para a passagem das lesiones. E os conectes com High Torque, que têm peso em la punta. Estes são os melhores, dependem para que você necessite usar, você elege uma ponta ou outra, como, por exemplo, para anatomia com deságue reto e leve, e lesões calcificadas moderadamente. Podemos usar um tipo de 12 gramas, tá? Que é para lesões mais anatomias tortuosas, porque é mais flexível, e aumentar o peso da punta. E usada também em oclusões calcificadas moderadas. E um fio mais pesado, que é de 30 gramas, que tem um maior poder de penetração e é usado para calcificações muito pesadas. O outro dispositivo que veio a melhorar muito os resultados do tratamento endovascular de los pacientes diabéticos e dos pacientes com isquemia crítica são os catéteres de suporte, tipo Rubicon da Boston, Quick Cross da Spectranetics e Surcross da Merit. São catéteres que ajudam muito quando tendremos a passar uma lesão e não conseguimos com os catéteres normais. Os estentes miméticos, como Supera da Abbott e Smart Flex da Cords, que têm objetivo de melhorar a compressão, são fortes para evitar a compressão de los estentes e têm resultados de trials muito buenos. Esses são alguns casos desafiadores, são todos pacientes diabéticos. Eu selecionei alguns, principalmente este que vocês podem ver que ela tem 2 estentes, uma oclusão femoropoplítea, porém tem uma artéria fibular aberta, pérvia, e 2 estentes. Aí, vocês podem me contestar a respeito disso. Eu vou falar para vocês agora. Este paciente foi submetido a um bypass. Este bypass ocluiu, foi para a cirurgia endovascular em outro serviço, e tentaram colocar estentes para abrir o bypass, claro, com não lograram êxito neste paciente. Então, eu tentei por la artéria nativa, e passei a lesão, e yo puse un estente supera. Tá? Aquí tiene la principal lesión, acá, la angioplastia, e interpus un estente supera, e se quedou muito bem, como vocês podem ver em la angiografia final. Esta é uma paciente diabética. Este segundo caso também tem uma oclusão poplítea, como vocês podem ver. Tá? Esses pacientes são diabéticos e são gravíssimos. Aqui, eu também usei a técnica de angioplastia com balão sem droga e depois o implante de lo estente supera um estente mimético. Este é o resultado final. Como vocês podem ver, aquela lesão gravíssima é um task D e aquele resultado final. Aqui temos a lesão pré e pós. E aqui, como ela chegou em meu consultório, é uma paciente com síndrome de Down e tem também diabetes. E aqui, após 30 dias. Este é um outro caso que tem uma lesão, uma obstrução poplítea também. E quando hicimos a angiografia, não tinha nada para baixo, a não ser como runoff, uma artéria fibular. Esta paciente não logrei passar por arriba, então eu cateterizei por abaixo por acesso retrógrado, a artéria tibial anterior, com o uso de ecodoppler, e aqui tem a tentativa de subida del hilo, command, que conseguimos acá vencer a lesão e revascularizar esse paciente, que se quedou assim, tá? Angioplastia. E este é o resultado final. Os outros temos usado também esta técnica de aterectomia, e aqui em Brasília é disponível a aterectomia direcional, com turbo halt, ou aterectomia rotacional, com rotablator e jetstream, e aterectomia por laser turbo tandem. Então, eu tenho usado muito a aterectomia, tá? Por jetstream, que é uma aterectomia rotacional, onde tenho lá o cortador frontal, aqui com estas lâminas, uma aspiração ativa e um lumen concêntrico, rotacional, que as lâminas se expandem. Então, aqui é um caso de uma paciente diabética, que eu usei jetstream e balão do tônix com droga. Tá? Então, essa é uma paciente que eu tenho duas lesões importantes e ela tinha uma úlcera del pé. Aqui vemos o tratamento pós-angiosete, ou jetstream. Aqui é o jetstream. E após o jetstream, nós hicimos a angioplastia com balão com droga Lutonix. E aqui é a passagem de jetstream hasta la poplítea. Este é o resultado final, muito bueno. y aquí la recuperación de toda la árvore arterial del paciente. Entonces, cuando pensamos en cirugía abierta o endovascular, pensamos cuál la mejor conducta terapéutica. La mejor conducta terapéutica es baseada en nuestros guidelines y la individualización del paciente. Entonces, tenemos lo TASC 2, que recomienda la cirugía como tratamento de escolha para lesões tipo B, tipo D, e quando tem pacientes com bom estado clínico, para lesões tipo C, cirurgia. Porém, para TASC A, cirurgia endovascular. Porém, os guidelines da ISVS traz para nós recomendações muito importantes. Quando temos as lesões oclusivas femoropoplítea, recomendações classe 1, nível C, endovascular, uma estratégia primeira de endovascular é recomendada nas lesões curtas, tá? Implantação de stent primário deveria ser considerado em lesões curtas também. Uso de balões, drug-eluting, devem ser considerados em lesões curtas. Stents eludidos por drogas devem ser considerados para lesões curtas. Todos 2A, 2B, 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 com nível de científica muito buenos. Porém, em pacientes que não têm alto risco para cirurgia, bypass cirúrgico é indicado para lesões longas, classe 1, nível B. Lesões de artéria femoral superficial, quando uma veia autóloga está à disposição do cirurgião, ela é indicada, porque se o doente tem uma expectativa de vida maior do que 2 anos. Veia safena autóloga, ela é o conduito que podemos elegir para o bypass femoropoplíteo. Quando o bypass abaixo da rodilha é indicado o uso de conduito protético, deveria ser considerado na ausência do substituto autólogo. Tá? Em pacientes que não são ideais para a cirurgia, a terapia endovascular deveria ser considerada em lesões longas, em lesões femoropoplíteas. Em pacientes com recomendações na revascularização infrapoplítea de lesões oclusivas. No caso de esta nova classificação, CLTI, infrapoplítea revascularização, é indicada para salvamento de membro, para resgate de membro. Para revascularização infrapoplítea, de artérias infrapoplítea, a vena indicada para o bypass é a vena safena interna. E a terapia endovascular deveria ser considerada também em Chronic Limb Treatment Schema. Quais são os... porém, nós temos um problema para os pacientes com lesões calcificadas em la poplítea de alto grado. Pacientes submetidos a procedimentos endovasculares que não logram passar a lesão através de alto grado de calcificação, devemos pensar em la cirurgia aberta pronto, como os índices de fracasso e reajustes são altos. Sim, aí consideraria a possibilidade de uso de cirurgia aberta. Tomaselli tem um paper muito bueno sobre isso, porque esse é de 2014, onde ele hizo una clasificación con prevalencia, mecanismo, detección e implicações clínicas. E o impacto da calcificação nos resultados clínicos depois da terapia endovascular. Então, como podemos ver acá, este esquema, esta classificação de PA-CSS, Peripheral Artery Calcium Score System, onde vemos que o grado vai aumentando conforme o aumento da calcificação. Este é um problema para os tratamentos endovasculares. Então, ele conclui que o score de cálcio da artéria femoral, um score alto de cálcio na artéria femoral poplítea, aumenta a perda de permeabilidade e o risco de tratar a revascularização da lesão-alvo. E aqui podemos ver também que ele conclui que se temos um runoff ruim, pobre, também impacta diretamente em la permeabilidade a um ano. E principalmente para estes pacientes de Sistema Único de Saúde aqui de Brasil, os custos de nossos pacientes frente a novas tecnologias são muito altos. Então, para os pacientes do Sistema Único de Saúde, a cirurgia aberta é uma alternativa de tratamento mais econômica. O maior custo de procedimentos endovasculares são por las novas tecnologias. Então, às vezes, no Sistema Único de Saúde, nós temos problemas sérios. As taxas de reintervenção em paciente tratado por cirurgia endovascular são mais altas. A cirurgia aberta tem um menor custo de materiais, mas com gastos de maior instância no hospital. E as taxas de permeabilidade são similares quando tratamos de pacientes com lesões femoropoplíteas. Então, a conduta terapêutica elegida para o paciente deve ser individualizada. Então, não se morrer a cirurgia aberta. A cirurgia aberta é uma alternativa muito interessante para o paciente que não tem acesso às terapias mais novas. E para o treinamento do residente de cirurgia vascular, este tem que também conhecer toda a anatomia num paciente aberto submetido à cirurgia aberta com cortes. Então, quando pensamos em bypasses e cirurgia aberta, podemos concluir, senhoras e senhores, devemos, sim, seguir os guidelines ou as diretrizes. Acreditamos em evidência científica séria, sim, claro. Devemos estudar todas e nos nortear por elas. Porém, devemos individualizar nossos pacientes e pensarmos em segurança. Em situações específicas, o custo se torna primordial. E o nosso arsenal terapêutico tem que continuar amplo. Para isso, devemos estudar sempre. Obrigado por sua atenção. Viu, Vitor? Muito obrigado. Thank you for your attention. Gracias por tu attention. Disculpe por lo retraso.
No, estuvimos a tiempo. Muchas gracias, tremenda conferencia. Tengo muchas preguntas para el doctor Moraes, sin embargo, vamos a abrir el panel de una vez a los que tenemos acá panelistas muy destacados como el doctor Ricardo Alinei, si está allí y quiere hacerle alguna pregunta al doctor Moraes. Si no lo tenemos por allí, Hugo, el doctor Hugo Navas de Venezuela, ¿alguna pregunta?
Hola. Sí, buenas noches. Felicitaciones, doctor Moraes. Una excelente revisión. Muchas gracias por compartir con nosotros toda su experiencia. La situación social, pues muy parecida en casi todos nuestros países latinoamericanos y en Venezuela, pues muy parecido a lo último que usted mostró. en relación a que las posibilidades de hacer tratamientos endovasculares en los centros privados en forma masificada, pues es improbable en el momento actual en Venezuela. Esperemos que en algún momento eso mejore. Coincido con usted que si ese fuera el caso, pues igual los residentes tendrían que ser entrenados en los procedimientos abiertos, si fuera el caso que los endovasculares fueran la mayoría, porque pasaría como la situación del entrenamiento de cirugía laparoscópica, que los residentes muchos no tienen experiencia en cirugía abierta y eventualmente cuando se complica o no se puede resolver un problema por laparoscopia, no hay la experiencia para hacerlo abierta. Igual esto aplica para el caso vascular. Mi pregunta es, al final usted comentó mucho en relación a las calcificaciones, pero refiriéndose específicamente a las calcificaciones arteriales. Y mi pregunta es la importancia que puede tener para el pronóstico de permeabilidad a largo plazo de un bypass utilizando una vena safena, la cantidad de calcificaciones en la vena safena. Es protocolo de ustedes estudiarlo. ¿Hace alguna diferencia hacer un bypass con unas arterias safenas con una proporción de calcificación elevada a largo plazo en la incidencia o en la afectación de la permeabilidad a largo plazo de ese bypass?
Sí, gracias por la pregunta, Hugo. Fue muy buena porque nosotros tenemos el protocolo de estudio pre-cirugía de la vena safena. Entonces, como nosotros tenemos acá un servicio de residencia en cirugía vascular y endovascular, nosotros tentamos elegir todo tratamiento. Puede hacer con vena, si la vena estiver disponible, es buena. Con la vena tiene un poder de dilatación hasta 4 a 5 veces su tamaño. Entonces, nosotros cuando utilizamos las venas, hacemos con ex vivo, hicimos la valvulectomía de la vena usando el valvulótomo de Mills, y hacemos la inversión de la vena o la inversión de la vena. ¿tá? Entonces, nosotros usamos la vena cuando ella está muy buena. ¿tá? Cuando tenemos una safena buena, es usada. ¿Por qué? La vena yo hablo como debris por dentro de la vena, ella tiene problemas para dilatar esta vena y para usar el valvulótomo. Entonces, preferimos ahí, cuando tenemos algún problema con la vena, usar los tratamiento endovascular.
Gracias.
Doctor Canata, perdón que recién no abrí el micrófono porque no lo podía abrir.
Adelante, doctor.
Gracias. Pero le quiero hacer al doctor Moraz, que hizo una excelente presentación de cirugía vascular, que me parece extraordinario que primero abramos o sepamos manejar la cirugía vascular abierta y luego hacer por endovascular. Y me voy a ir un poquito más arriba del circuito femoropopliteo, ¿no? Yo le quiero hacer una pregunta. ¿Qué experiencia tiene usted con un bypass largo axilofemoral? Cuando tiene oclusiones severas en todo el territorio aórtico y femoral pélvico, ¿no? Esa es mi pregunta, doctor Moraes.
Gracias, doctor Aline. Nosotros hemos hecho claro, las anastomosis, los axilos femorales, porém, son cuando no tenemos nada más a hacer. ¿ah? Porque es un bypass que llamamos extraanatómico, que tiene una morbimortalidad muy alta como infecciones y principalmente con una perviedad muy baja. Porém, en pacientes de alto risco para cirurgias de aorta o que não têm a possibilidade de la cirurgia endovascular, aún é um procedimento que tem resultado muito bom, porque ele tem uma taxa de infecção alta, porém é muito, não digo sencillo, porém é um bypass factível. ¿Usted entiende? Entonces, usamos, yo creo que en este último año, de 2019, hicimos 4 injertos bypasses axilofemoral, 3 bifemoral y 1 axilofemoral.
La segunda pregunta que le quiero hacer, estimado doctor. Con los resultados que usted me dice, concuerdo totalmente. Y para prevenir una trombosis distal, ¿no es cierto? Para no prevenir, para que darle una calidad de vida mejor al paciente. Una conducta médica, como por ejemplo, antiagregarlo o anticoagularlo para prevenir que la tenomatosis de los miembros inferiores que ya tienen una mala circulación haga que se ocluya los extremos inferiores y tengamos ya que amputar a un nivel muy bajo y nos quedaríamos sin paciente.
Sí, doctor Liney.
¿Qué opina usted de esta conducta médica?
Doutor Liney, eu concordo com você porque é importante 2 coisas. Primeiro, estudarmos bem o paciente com relação ao runoff. Quantas artérias temos para que receberão o bypass se é femoropoplíteo? Quantas artérias tibiales eu tenho disponíveis para o bypass? Esse é ponto muito importante. Com relação à agregação do paciente, eu penso que a cirurgia aberta, nós devemos usar sempre 2 antiagregantes. Hoje usamos a aspirina, a OAS, e clopidogrel. Porém, em pacientes com endovascular, com cirurgia pós-operatória de cirurgia endovascular, nós estamos começando a usar o protocolo de Compass, de Xarelto, 12,5 miligramas, 2 vezes por dia, junto com aspirina.
Excelente. Tenemos todavía...
Muchísimas gracias, doctor. Ha sido usted muy amable. Gracias por su respuesta.
Gracias, Ricardo.
Gracias, doctora Liney. Le decimos al doctor Moraes, hay todavía muchas preguntas allí en el chat. Sin embargo, vamos a proseguir, no se nos retire, doctor Moraes. Vamos a proseguir con el doctor Tomás Alberti, nuestro próximo expositor. El doctor Alberti es past president de la Sociedad Venezolana de Flebología, director de la clínica Angios, y quiero decir también que pertenecemos a la misma escuela de cirugía cardiovascular del Hospital Clínico Universitario de Caracas, así que un abrazo y bienvenido al doctor Tomás Alberti con su conferencia Cuidado avanzado de heridas en el pie diabético.
Gracias, doctor Viloria, compañero de posgrado por lo visto. Es una muestra de la Unión Latinoamericana esto, ¿no? Es decir,
correcto.
Tenemos formaciones comunes, hay gente que se ha formado en Argentina, en Brasil.
Disculpe, doctor, se oye un poquito bajo el micrófono.
Déjeme subirlo. Mejor.
Un poquito mejor. Creo que hay algún problemita ahí.
Déjenme. ¿Así será mejor? Aló, 1, 2, 3, 4.
Se escucha, pero se escucha como un poco lejos, doctor.
Ok, ¿me podrá dar un segundo para entender esto?
Bueno, mientras el doctor arregla ahí los problemas técnicos al tino, el jet stream no necesita filtro para el jet stream, ¿no? Porque a veces lo que hay que comer es filtro distal para los otros aterótomos. Yo estoy usando acá el Phoenix, que es de Spectranetics. ¿Es parecido al Phoenix, el jet stream?
Gerardo, no se necesita filtro porque ellos tiene una aspiración activa. Entonces, por él tiene es rotacional. Ele tiene láminas que van a destruir la placa e inmediatamente lo suga, lo quita los detritos por aspiración. Entonces, agora, yo no conozco la Phoenix, este dispositivo.
Yo creo que es muy parecido. Parece que el doctor Alberti ya lo tenemos de nuevo.
¿Aló? ¿Pruebas ahora? ¿Mejor?
Un poquito mejor, doctor.
Mejor. Deme un segundito más. Vamos a volver a probar una cosa.
Ajá, bueno, seguimos acá mientras tanto con
Can
Altino.
we just, I would like just to know also, Anil, what kind of device, and also Dr. Mills, what kind of device of atherectomy that usually you use? And what is your experience? Tino has some stuff already done. Do you have something that you can tell us? And also Dr. Mills.
Unfortunately, we've been dabbling with the atherectomy devices for decades since they've come out. And we've been through all the ones that were mentioned on the excellent talk. And we've had all the complications from all of them that you can possibly imagine, as you'd expect. We've actually backed off from the atherectomy devices again, and we're using them exceedingly rarely. A lot of our hesitation has not only been from the complications that we've had, but also the lack of efficacy that we've had in our patients. And furthermore, the lack of data, randomized prospective level 1 data, despite the thousands of uses that are taking place in the inpatient and the outpatient setting worldwide. So we are actually skeptics. We try it, certain patients, when a new one comes out, and we often stop using it after the lack of efficacy in our patients.
Verificamos acá con el doctor Alberti nuevamente.
Ahora esperemos que la tercera sea la vencida.
Perfecto, perfecto, Tomás. Adelante.
Voy a compartir pantalla. Vamos a ver, compartir pantalla. ¿Sí? ¿Ve la pantalla?
La estamos viendo perfectamente.
Bueno, muchas gracias primero por invitarme y felicito al doctor Canata por haber reunido este realmente extraordinario grupo de cirujanos. Es un privilegio compartir opiniones con el doctor Mills y el doctor Hingorani y nuestros amigos de Brasil y el resto de las personas que nos ven en Latinoamérica. Mi tema es el cuidado de heridas. El cuidado de heridas siempre termina de último, pero para mí realmente es una historia de amor. Cuando yo era cirujano general, habían 2 cirujanos vasculares en el servicio donde yo trabajaba. Y en ese momento, claro, un servicio de cirugía general estaba interesado, estamos hablando de los principios de la laparoscopia, estaba interesado en la laparoscopia, estaba interesado en cáncer, estaba interesado en trauma, y decían que estos cirujanos, que también eran cirujanos generales, tenían el servicio lleno de patas en criollo, ¿ok? Y los pies diabéticos pues eran para ellos problemas de pie, y eran unos problemas relativamente despreciados. Vengo a decirles que no es así. ¿Estamos oyendo bien? ¿Aló? ¿Aló? vengo a decirles que no es así. Para los pacientes, básicamente, como dijo el doctor, el doctor Hingorani, creo que fue el que dijo, que prácticamente el conservar la libertad de caminar, el conservar la capacidad de ser independiente es una de las cosas que los pacientes más aprecian. El salvar una pierna o salvar un pie es realmente una cosa extraordinaria. Desde el punto de vista, entonces, desde el punto de vista humano, desde el punto de vista del interés del paciente, el cuidado de heridas es sumamente importante. También es importante desde el punto de vista médico, porque es una especialidad o es una ocupación en la cual mantenemos una relación muy particular con los pacientes. Los pacientes llegan a hacerse amigos de nosotros. En muchos sentidos es de lo que se trata ser médico, tener una relación personal con los pacientes y, ¿cómo se llama?, poderlos ayudar. También es intelectualmente un asunto muy importante y muy interesante porque nuestro conocimiento de los procesos de cicatrización y cómo acelerarlo es bastante fragmentario. En el pie diabético todo esto toma otra importancia. Las úlceras más comunes, los problemas más comunes de heridas crónicas son vasculares. Tenemos el pie diabético, las úlceras venosas, las úlceras isquémicas. Todas estas cosas son excesivamente frecuentes y como elemento definitorio tienen una ubicación común en la pierna. Todos son defectos cutáneos. Al ser un defecto cutáneo, al ser una úlcera, un defecto, todos tienen un potencial de infección. Y también al ser un defecto cutáneo, todas estas úlceras toman tiempo en cicatrizar porque los procesos biológicos tales como crear un tejido donde no lo había es una cosa que toma tiempo y no es inmediata. También tienen una estrategia de tratamiento común. La estrategia de tratamiento común más apropiada es el tratamiento causal más el tratamiento local. Es decir, no es un asunto de tratamiento local, de usar el superapósito, el superfactor de crecimiento, sino que el cuidado de heridas tiene que verse integrado en un esquema de tratamiento que a su vez identifique y trate las causas al mismo tiempo y de manera simultánea. El cuidado de heridas se inventó hace mucho tiempo ya. Es un conjunto de técnicas para ayudar a cicatrizar una úlcera crónica. Prácticamente estas técnicas solamente toman valor en heridas que tienen factores anticicatrización, porque las heridas, por ejemplo, traumáticas y las heridas quirúrgicas, pues tienen potencial de cicatrizar incluso en contra de los errores que se puedan cometer. El cuidado de heridas húmedo se basa en una serie de apósitos para mantener la humedad en la herida. Estos apósitos son más o menos absorbentes, más o menos húmedos. Hay varias generaciones de estos apósitos y todo esto viene de tecnologías y trabajos de investigación que fueron desarrollados en los años 60 y no fueron desarrollados en realidad para heridas crónicas. El trabajo seminal de toda esta tecnología que se ha convertido en una enorme industria en el mundo entero fue un trabajo que se hizo en quemaduras experimentales en lomo de cochino. Entonces pudiéramos decir que probablemente unas tecnologías que se hicieron para inicialmente para acelerar la cicatrización de heridas no crónicas tal vez no sean completamente aplicables al pie diabético. Sin embargo, hay una serie de principios básicos en eso. El primer principio es no dañar en cuidado de heridas. Dañar puede ser de muchas maneras. Dañar puede ser colocando soluciones citotóxicas, por ejemplo, prácticamente todo lo que la gente normalmente coloca, oxigenada, betadine, toda clase de antisépticos son citotóxicos y retrasan la cicatrización. No dañar también implica no hacer curas a cada momento. Una persona, un paciente que recibe curas todos los días, está dañando mecánicamente cada vez que se levanta la gasa que cubre la cura. Y también las curas en medio húmedo, el uso de todos estos apósitos tecnológicos que no se pegan a la herida, también pertenece al principio de no dañar. Hay otros puntos además. La herida tiene que ser evaluada de una manera objetiva, tiene que ser documentada probablemente, y la trayectoria de cicatrización es muy importante para diseñar lo que vamos a hacer dentro del tratamiento local del paciente. Entonces, todos estos principios son aplicables tanto a las úlceras venosas como a los pies diabéticos y demás heridas crónicas. Sin embargo, no son exactamente aplicables. Es verdad que en condiciones de humedad, la fase inflamatoria y de granulación de la cicatrización de una herida ocurre de una manera más rápida, que es el motivo por el que secar una herida con polvos, gasas, tener una herida descubierta es inapropiado. Pero los pacientes diabéticos, esta herida, por ejemplo, pues es correcto manejarla con apósitos húmedos. A esta herida podremos colocarle cualquier cosa, incluso tal vez un hidrocoloide, es una herida completamente granulada, completamente cubierta. Este tratamiento basado en apósitos húmedos tiene evidencia. En realidad tiene poca evidencia de nivel 1, básicamente porque los trabajos que se han hecho son pequeños, faltos de poder estadístico, hay muchos conflictos potenciales de interés y hay un problema más serio. La mayoría de estos trabajos prueban simplemente un apósito contra otro o un tratamiento contra otro. Y los apósitos no son apropiados, el mismo apósito no es apropiado durante toda la trayectoria de cicatrización de una herida y a veces ni siquiera es apropiado en una parte, puede ser apropiado en una parte de la herida y puede no serlo en la otra. Entonces, estudios que prueben el apósito A contra el B, pues obviamente pues no pueden funcionar muy bien y no han tenido resultados que demuestren superioridad estadística de algún tipo de estas tecnologías sobre otras. También se ha desarrollado un protocolo para evaluar en una forma sistemática las heridas crónicas, que se llama TIME. Esto no es exactamente el propósito del asunto en el pie diabético, porque el pie diabético tiene muchas más cosas. Entonces, es verdad que tal vez la cicatrización en medio húmedo, que tal vez no dañar la herida sean principios correctos. Pero en el pie diabético el tratamiento causal, además del tratamiento local, toma completamente otra importancia, porque en pie diabético pues tenemos tres enormes elementos. Tenemos el elemento del déficit de flujo, que fue tratado excelentemente por el doctor Mills y por el doctor Hingorani. Tenemos el elemento tisular, porque es verdad que estas úlceras muestran una capacidad de cicatrización que está alterada más allá de lo que podemos predecir simplemente de acuerdo al déficit de flujo, porque algunas de ellas pues tienen meses y entonces eso produce ciertos cambios fenotípicos en la herida que hacen más difícil cicatrizar. Sin embargo, hemos de decir que de las heridas crónicas, el pie diabético es el menos crónico de todas las heridas. No es lo mismo lidiar con un pie diabético que tiene 2 o 3 meses que con una úlcera venosa que tiene 10 años. Las alteraciones tisulares de senescencia local, las alteraciones fenotípicas de una úlcera venosa serán mucho mayores que en el pie diabético. Y en ese sentido, la úlcera venosa es el benchmark de la úlcera crónica. El pie diabético no exactamente. En el pie diabético tenemos este gran problema del déficit de flujo y tenemos el gran problema de la infección, que fue ya un factor tomado en cuenta también por las personas que me predijeron. Pero fíjense ustedes, en la nomenclatura hay cosas interesantes. A pesar de que estamos yendo cada vez a una forma más integral de ver esto, lo cual se ve en la clasificación Wi-Fi, donde se describen factores relacionados con la herida, con el flujo y con la infección. De todas maneras, como nosotros llamamos las cosas, es importante. Entonces, por ejemplo, tenemos la iniciativa Toe and Flow, ¿ok? La iniciativa Toe and Flow del maravilloso grupo de Arizona, Salsa. Entonces, Toe and Flow, a veces es Flow and Toe, pero where is infection in there? ¿Ok? Entonces, hay Toe, hay Flow, y la infección pareciera no pareciera tomar toda su importancia. Y también existe este otro grupo muy interesante a nivel mundial que se llama Cliff Fighters, que es como se llama, organizado por el doctor Jihad Mustafa, un gran revascularizador. Entonces, en un pie diabético tenemos un problema de flujo, tenemos un problema de infección y además de una herida crónica. ¿Por qué no hay neumonías diabéticas? ¿Por qué solo pie diabético? Bueno, hay factores anatómicos en el pie que son factores muy particulares. A pesar de que los diabéticos, yo soy diabético tipo 1, tenemos una posibilidad incrementada de tener infecciones, pues no hay neumonía diabética ni hay apendicitis diabética. ¿Por qué pie diabético? Bueno, hay factores anatómicos que son varios. Uno de los más importantes son los compartimientos del pie. Eso hace que en el pie, que es una estructura con múltiples compartimientos, si tenemos una infección profunda, es muy fácil generar un síndrome compartimental infeccioso. que causa pues grandes problemas desde el punto de vista tisular. También en términos militares podemos decir que el pie es una estructura falta de retiro estratégico. La distancia que hay entre la frontera del pie, entre la piel del pie, por ejemplo, una articulación interfalángica, y la articulación es de milímetros. La distancia que hay entre la piel del pie y ¿cómo se llama? Y el tobillo realmente es muy poca. Entonces, el pie tiene compartimiento, el pie tiene piel muy cerca de una serie de estructuras vulnerables. Eso hace que la osteomielitis siempre sea permanentemente un peligro. Y además el pie tiene una serie de vías de diseminación por tendones, por articulaciones. Eso probablemente es lo que hace que exista el pie diabético más que los factores relacionados con la diabetes en sí. Si los factores relacionados con la diabetes fuesen el asunto, pues existieran capítulos especiales de infecciones para todas las infecciones en diabéticos y no es así. Entonces, la infección es un gran problema en el pie diabético y ocasiona un círculo vicioso de pérdida tisular. Funciona sinergísticamente con la isquemia. La osteomielitis, los síndromes compartimentales infecciosos, abscesos profundos, artritis séptica, esas son las cosas que nosotros tenemos que detectar en un pie diabético. Ese es el motivo por el que el pie diabético en muchos sentidos no es un asunto de cuál apósito poner. Es un asunto en muchos sentidos quirúrgico. Es una infección que debe ser tratada quirúrgicamente. Entonces, el debridamiento, que es el nombre de retirar el tejido necrótico, retirar, ¿cómo se llama?, el tejido desvitalizado, en el pie diabético no solamente es parte del cuidado de herida, es un tratamiento causal. Y las curas, nosotros tenemos muchos problemas con el nombre de cura. Las curas o curaciones, como le dicen algunos países latinoamericanos, no son curas de poner un apósito y quitar el apósito y hechas frecuentemente por el personal de menos capacitación. Las curas son operaciones, ¿okay?, más grandes, más chiquitas. En realidad son tratamientos quirúrgicos de un problema infeccioso y de un problema de cuidado de herida. ¿Cuáles son los peligros principales en el control de la infección? Diagnóstico inapropiado de la extensión de la infección. Es decir, podemos tener una herida relativamente pequeña, donde hay una infección periherida relativamente pequeña y sin embargo nosotros tener abscesos profundos, osteomielitis, todo lo demás. Otra cosa que vemos frecuentemente es la timidez en la antibioticoterapia. La antibioticoterapia de un pie diabético es, si el pie diabético es importante, es agresiva. Y una vez que tengamos cultivos, nosotros debemos desescalar cómo se llama la antibioticoterapia, pero inicialmente, aunque no es el tema de la conferencia, yo pondría antibióticos de la mejor calidad y la mejor cobertura en un pie diabético serio. Y el otro problema que tenemos es que los apósitos, es verdad que los apósitos protegen al tejido, favorecen el tejido de granulación, pero la humedad es proinfección. Entonces, si nosotros colocamos apósitos húmedos en un pie diabético, corremos el riesgo de perder más, potenciando la infección, que lo que ganamos por el efecto de la humedad a nivel de cuidado de herida. La importancia del flujo apropiado ya lo vimos suficientemente. El flujo es un prerequisito para que el cuidado de heridas pueda tener éxito. Y eso es lo que vemos, ¿cómo se llama?, entronizado en la clasificación Wi-Fi y también en la clasificación de Texas, que son integrales, es decir, tienen en su seno la idea de que tenemos que tomar en cuenta tanto la infección como el déficit de flujo, como las características de la herida. Entonces, hace muchos años que se ha establecido que el modelo de atención correcta para estas enfermedades que son muy complejas es multidisciplinario. Entonces, por ejemplo, el grupo de Arizona preconizó un mínimo irreductible, el doctor Armstrong, un mínimo irreductible de un cirujano vascular y alguien que se ocupe del pie, es decir, lo que llaman el flow team y el toe team, ¿ok? Sin embargo, el problema de los equipos multidisciplinarios es que muchas veces son asincrónicos. Sería ideal si todas las personas pudiéramos, ¿cómo se llama?, tomar decisiones a la vez y si el tratamiento pudiera hacerse realmente en conjunto, pero frecuentemente no es así, es uno primero y uno después. Esto trae una serie de retrasos y una serie de inconvenientes que en pie diabético, que es una enfermedad que puede ser muy rápida, pueden ser importantes. Luego viene el asunto de quién se encarga de qué. Esto es una imagen del mismo grupo. Entonces ellos, por ejemplo, si el flujo es particularmente inadecuado, es el equipo de flujo el que toma la primacía, mientras que si el flujo es adecuado, el equipo que se ocupa del pie es el que toma la primacía. Y en casos de perfusión marginal o de perfusión insegura, en los que no estamos seguros si existe la capacidad de cicatrización o no, pues deberían actuar los dos. Nosotros, por una serie de problemas, no llegamos a funcionar nunca así. ¿Por qué no? En Venezuela, ya ahorita lo vamos a conversar mejor, pero nosotros tenemos un modelo de atención diferente. Hablamos de un modelo de atención especializado. La idea no es tener diferentes personas que tengan los diferentes conocimientos, sino los diferentes conocimientos dentro del mismo cerebro. ¿Okay? La idea es tener un especialista vascular que tenga el manejo de la medicina vascular que tiene tradicionalmente, históricamente, un cirujano vascular, que tenga capacidad de cirugía abierta endovascular, que tenga capacidad de manejo del laboratorio de exploraciones vasculares y también tenga una capacidad considerable de cuidado de heridas. Entonces, eso es lo que nosotros consideramos el currículum para un especialista en salvamento de miembro o un especialista en medicina vascular de la pierna. Entonces, una de las preguntas que le hice al doctor Mills era si él pensaba que nuestra especialidad estaba tal vez fragmentándose. Si como hay una aorta team, si no debería haber tal vez un leg team, ¿ok? Pero el leg team pudiera ser un leg specialist, ¿ok? Y no un leg team. Entonces, ¿cómo llegamos a eso? Eso es un modelo que hemos evolucionado a lo largo de 25 años y en realidad se adaptó a una serie de limitaciones locales. En Venezuela es muy difícil conseguir un traumatólogo que se ocupe de pie. Eso es una casi imposibilidad. Ellos tienen mejores negocios de que ocuparse. Ellos se ocupan de cirugía artroscópica, ellos se ocupan de cirugía de rodilla y de cadera, etc. Y, ¿cómo se llama? Entonces hay limitaciones de manpower en muchos aspectos que nos han dificultado hacer esos equipos multidisciplinarios. Al final del cuento resultó mucho más fácil conseguir gente entusiasta por el salvamento de miembros, básicamente cirujanos vasculares, y entrenarlos en todo. También existen limitaciones económicos sociales que hacen que este tipo de modelo sea apropiado, porque un modelo donde un especialista se encarga básicamente de la mayor parte de la atención del paciente, por lo menos de la cadena de montaje principal, es económicamente más barato. Y también sucedió esto porque nunca tuvimos suficiente poder político, ni en los hospitales ni en las universidades, para nosotros realmente crear un servicio de cirugía vascular, mucho menos una unidad de cuidado de herida en los hospitales o universidades venezolanos. Existen servicios de cirugía cardiovascular que son 90% cardio y 10% vascular. Y en esos servicios, pues la parte vascular no ha tenido toda la importancia que debería tener. ¿Cuál es la ventaja de este equipo que llamamos simplemente para llamar la atención sobre eso? Un modelo de atención monodisciplinario, no multidisciplinario, una sola disciplina. Y la disciplina es salvamento de miembros, ¿okay? Salvamento de miembro o, ¿cómo se llama?, en enfermedades vasculares del miembro inferior, no definida de acuerdo a métodos de tratamiento, sino definida de acuerdo a enfermedades y objetivos. ¿Cuál es la ventaja de hacerlo así? Rapidez en evaluación y toma de decisiones, mejor coordinación, contención de costos. El paciente sabe quién es su médico tratante. Muchas veces en un equipo multidisciplinario, el paciente no tiene claro quién lleva la batuta, quién realmente es su médico. También es más fácil educar personas que educar equipos y tal vez sea incluso más escalable, porque por lo menos a nosotros nos resulta más fácil formar un cirujano con todos estos componentes de pensum que conseguir médicos de múltiples especialidades que estén interesados en ese tema. ¿Dónde nosotros hacemos eso? Bueno, en un centro vascular que se llama angio. Angio es una declaración de principio, porque a nosotros nos interesa más el angio que el cardio. Ese es el propósito del nombre. Y es muy particular porque es un centro vascular que está separado de los hospitales. Inicialmente nosotros salimos de una clínica privada, un gran centro privado, pero tiene alta capacidad resolutiva. En Estados Unidos existe últimamente una gran moda de centros vasculares, office procedures, pero no son como angios. ¿Por qué no? Porque ellos hacen básicamente pacientes de bajo riesgo. mientras que Ángeles tiene 3 camas de terapia intensiva, tiene 7 camas de hospitalización, tiene emergencias 24 horas, laboratorio, banco de sangre, diálisis, es decir, nosotros no tenemos que tratar con pacientes de bajo riesgo, porque básicamente hemos desarrollado la capacidad a lo largo de los años de poder tratar con cualquier cosa. Entonces, básicamente todos los pacientes que son piernas nosotros los tratamos aquí y excepcionalmente vamos a mi hospital de referencia, que sería la Clínica Santa Sofía. También tenemos quirófano híbrido, quirófanos de procedimientos endovasculares ecográficamente guiados, quirófanos de cirugía abierta, 7 máquinas de eco, tomógrafo multicorte, de manera que nosotros somos independientes tanto desde el punto de vista de diagnóstico como desde el punto de vista de tratamiento quirúrgico y endovascular. Entonces no tenemos problemas de schedule y manejamos el costo del proceso de cicatrización o de curación del paciente de una manera integral. Eso nos permite balancear el costo y no acabar con el dinero en una cirugía endovascular y entonces pues quedarnos sin dinero para los antibióticos o el cuidado de herida. Entonces, el centro de lo que somos es una unidad de cuidado de heridas, solamente que es una unidad de cuidado de heridas con quirófanos, salas endovasculares, tomógrafos, todo lo que necesita pegado. Entonces, tienen salas de cura pequeños, personal especializado, tiene salas de cura grandes, que son estas, son una cosa muy interesante, que las llamamos semiquirófanos, más adelante vamos a hablar de ellas. Y tenemos camárica y tenemos pues una cantidad de tecnologías, como se llama, que son avanzadas, pero no vamos a hablar tanto de ellas porque vamos a hablar de cuál es la base. El nombre de tecnologías avanzadas, de cuidado de heridas avanzado, es erróneo. Lo correcto sería emplear un símil oncológico. Hay, como se llama, tratamientos de primera línea y tratamientos de segunda línea. No podemos irnos a la segunda línea sin tener agotado o entender cómo funciona la primera línea. Desde el punto de vista de personal, tenemos 3 cirujanos cardiovasculares, 1 vascular, 3 fellows de cirugía vascular, tenemos un posgrado de cirugía vascular, 2 ecografistas y 5 enfermeras especializadas. Entonces, y además tenemos pues otra serie de especialistas para lidiar con las complicaciones. Nosotros tenemos intensivistas de guardia todos los días, cardiólogos que también usan nuestra infraestructura, tenemos cardiólogos clínicos, hemodinamistas, internistas endocrinos, nefrólogos, traumatólogos, neumonólogos y fisioterapeutas. Entonces, establecido quién y establecido en dónde, cómo pensamos que debe ser tratado, estas son quién y en dónde, bueno, es una adaptación a las limitaciones de nuestro medio. Como dicen los arquitectos, la función y la forma terminan, como se llama, siendo determinadas por el entorno. Pero aparte de eso, bueno, nosotros pensamos que existe una manera de tratar estas cosas que en muchos sentidos ya fue descrita por el doctor Hingorani, pero nosotros tenemos nuestras variedades que tienen que ver con este modelo monodisciplinario. Entonces, pensamos que la base de todo es una evaluación inicial correcta. El diagnóstico correcto es el prerequisito para el cuidado de heridas y para las intervenciones vasculares también. Entonces, el paciente llega y el paciente va a una consulta vascular y quirúrgica one-stop, es decir, nosotros vamos a obtener los datos clínicos, el examen clínico tradicional, le vamos a hacer un Doppler duplex en el mismo tiempo. Todos los pacientes van a tener Doppler duplex hecho por nosotros mismos. En ese momento tiene que hacerse una determinación de riesgo. ¿Cuál es el riesgo al miembro y a la vida del paciente? Tiene que identificarse los factores anticicatrización que el paciente tenga. Tiene que documentarse ecográficamente la úlcera y tiene que establecerse un plan de trabajo. Entonces, eso sería el primer punto. La parte de eco es clave en eso. La parte de eco y también la parte clínica tradicional. Entonces, ¿qué es lo que nosotros vamos a ver desde el punto de vista de observación, palpación, etcétera? Vamos a ver 3 cosas que nos interesan. Nos interesan las úlceras, nos interesa la necrosis y los problemas mecánicos, ya que del flujo vamos a continuar hablando después. Entonces, en cuanto a las úlceras, nos interesa su superficie, su profundidad, si hay contacto óseo y qué tanta infección hay. Hay que recordar que las úlceras son como el iceberg. Es decir, es muy importante que no tropecemos con ellos como el Titanic. Es muy importante descartar la posibilidad de abscesos profundos, osteomielitis, etc. Las úlceras del pie no son como las úlceras venosas en el sentido de que su importancia está definida por su superficie, ¿okay? O simplemente por el aspecto de la úlcera. La importancia tiene que ver con otros elementos que no son visibles aparte del flujo. Nos interesa ver si hay necrosis, cuál es su extensión, existe infección en la necrosis. Y tenemos que tomar en cuenta que la muerte tisular es un fenómeno local y es muy difícil diagnosticar una isquemia realmente irreversible. Entonces, decir que porque existe determinada necrosis que puede ser superficial, una pierna es no revascularizable o intratable, ir a una amputación primaria, a veces es una decisión difícil de tomar y muchas veces errónea. También nos interesan los problemas hepáticos, los problemas mecánicos, si existen deformidades, puntos de hiperpresión, neuropatía que agraven esto. Entonces, el examen físico debe hacerse, nosotros pensamos, con realidad aumentada, es decir, con máquinas de eco y con máquinas de rayos X para nosotros ver si existen osteomielitis, abscesos profundos, perfusión insuficiente, que son las catástrofes en potencia que nosotros tenemos aquí. Uno de los principales elementos de error en el tratamiento, en un esquema de tratamiento del pie diabético es el error diagnóstico inicial. Entonces, ¿cómo evaluamos la perfusión? La perfusión la vamos evaluando dependiendo de cuál es el déficit que el paciente tiene. Inicialmente, como todos los pacientes tienen Doppler duplex a color, la evaluación inicial es un análisis espectral de flujo. Si el paciente tiene un flujo de patrón obstructivo severo, que es lo que ustedes ven allí, eso lo podemos determinar en la arteria pedia, tibial posterior, poplitea, femoral y femoral común, probablemente en menos de 2 minutos. Nosotros sabemos si tenemos un problema de perfusión. Si tenemos un problema de perfusión, además vamos a obtener información anatómica. ¿Cuál es el segmento donde existe ese problema de perfusión? Existe en el segmento femoropopliteo, donde las intervenciones endovasculares son más fáciles, o existe en el infrapopliteo, donde son más difíciles. Dependiendo de lo que se consiga, entonces haremos tomografía, que para nosotros hacer una tomografía sube la planta baja, es la tomografía, y la tomografía está hecha en media hora probablemente. Y también podemos hacer pruebas de viabilidad tisular según la necesidad. Entonces, aparte de la evaluación, ¿cómo se llama? Tradicional de pulsos, temperatura, llenado capilar, todo lo demás, el eco y la evaluación instrumental por pletismografía, por pruebas de viabilidad tisular, es una base para el diagnóstico, pero todos los pacientes por lo menos tienen eco. Entonces, al final de la primera consulta, nosotros tenemos que establecer dos cosas. Si el paciente es un pie diabético crítico, es un pie diabético estable. Este concepto de pie diabético crítico viene de unos grupos italianos y es muy interesante. El paciente puede estar no solamente críticamente falto de flujo, puede tener una infección crítica. Entonces, un pie diabético crítico es una condición en la que el paciente se ve enfrentado a una pérdida tisular masiva o una pérdida del miembro o una amenaza directa contra la vida, bien sea por isquemia, infección, una mezcla de las dos cosas, pero en forma inmediata. Mientras que un pie diabético estable, pues es completamente otra cosa. Entonces, en un pie diabético clínico, ¿qué tenemos que hacer? El tratamiento tiene que ser inmediato, con 4 intervenciones simultáneas o consecutivas, debridamiento quirúrgico, antibioterapia agresiva, revascularización y control de condiciones comórbidas. En el pie diabético clínico, obviamente, el debridamiento, antibioticoterapia y revascularización es lo más importante y eso debe hacerse, pues, en forma inmediata, mientras que en un pie diabético estable, el asunto inicial es cuidado de heridas, descarga del pie diabético, control metabólico, condiciones comórbidas. Y las intervenciones vasculares o quirúrgicas adicionales serán según los resultados. Entonces, en un mal perforantar, pues nosotros no estamos en una condición inestable y los manejamos de diferentes maneras. Entonces, esto no viene tanto al caso, pero es importante que las revascularizaciones se hagan con conciencia de cuál es el déficit de flujo que cada lesión ocasiona. No necesariamente tenemos que arreglar todo, no necesariamente tenemos que establecer una vía directa de flujo hasta el pie en un paciente determinado. Eso depende de qué tan importantes sean las lesiones proximales. También depende de cuál es, ¿cómo se llama?, cuáles son las condiciones del paciente. Tal vez un paciente que pueda aguantar una intervención endovascular de media hora, le resulte más difícil aguantar una de 3 horas. Entonces, ¿cómo hace eso? Hacemos análisis espectral de flujo en diferentes regiones de la pierna. Por ejemplo, en este caso, que es una antigua, esto es hecho con una máquina de eco antiquísima, por allí por el año 2000, para planificar una revascularización ultradistal en la época quirúrgica. Se ve que tenemos, a pesar de que hay enfermedad infrapoplitea, tenemos una lesión muy importante en la poplitea retrogenicular y tronco tibio-peroneo que producen un enorme flujo de patrón obstructivo severo. Entonces, también por medición de presiones segmentarias podemos hacer esto. Hay que recordar que el potencial de cicatrización es cosa difícil de determinar, porque no solamente tenemos el flujo global, que es lo que medimos con el índice isquémico o el índice tobillo-brazo o el índice dedo-brazo. Tenemos problemas de flujo.
Doctor Alberti, disculpe que lo interrumpa. Estamos un poquito contra el tiempo. Está excelente pero sí, le damos unos minutitos más. Adelante.
Entonces es importante establecer localmente por diferentes métodos, establecer cuál es la perfusión local. Entonces, el pie diabético, el tratamiento correcto tiene que ser enfocado, balanceado. Hay que balancear el dinero, el tiempo y el manpower, con cuidados locales, irrigación, control de la infección, factores mecánicos y sistémicos. En todo eso, el cuidado de heridas es muy importante, porque al final de todo este asunto es una pérdida tisular. Entonces, el cuidado, el cierre de la lesión es lo que se busca. ¿Cuáles son los objetivos del cuidado de heridas? Preservar el tejido y la función, controlar la infección, cubrir los tejidos profundos, y todo esto tiene que hacerse rápido y en un ambiente de contención de costo. Como existe una dificultad para predecir el potencial de cicatrización y un potencial permanente de infección, este proceso pues tiene que ser gradual, porque no estamos completamente seguros qué tejidos debemos quitar y cuáles no. Cortar por lo sano en cuidado de heridas es una mala idea. Es mucho mejor esperar y ver, es decir, debridar, ver qué pasa, esperar y ver. La paciencia y el juicio y el valor para no salir corriendo, hacer cosas apresuradas de una vez, son las virtudes del cuidado de heridas. Y decimos que los pies diabéticos son como los bonsáis, se jardinean, los hacemos crecer por un lado y los recortamos por otro. El cuidado de heridas es una acción progresiva, vamos a hacer determinadas cosas y vamos a controlar esta acción mediante los resultados y vamos a hacer otras. Y ya dijimos que son operaciones. Entonces, ¿cuáles son los elementos del cuidado de herida? El debridamiento, eso es un gran arte, porque si cortamos de más es malo y si cortamos de menos también. Las formas correctas de debridamiento son el quirúrgico y también el hidrodebridamiento. Su propósito es retirar el tejido necrótico, desvitalizado, osteomielitis, reducir la carga bacteriana, abscesos y biopelículas. Pero, ¿cómo se llama? Pues nosotros no vamos a quitar todo de una vez, porque preferimos quitar el tejido necrótico progresivamente para nosotros ver realmente cuál es el potencial de cicatrización de determinados tejidos. ¿Qué vamos a hacer con los apósitos? Vamos a disminuir el daño tisular, favorecer el crecimiento de ciertos tejidos, vamos a controlar la humedad. Hay algunos antisépticos locales y apósitos biológicos. El problema es que la humedad es proinfección. Entonces, los apósitos húmedos pueden debridar la herida además, y la humedad también puede hacer, como se llama, simplemente que progrese la infección si nosotros usamos apósitos oclusivos. ¿Quién debe hacerlo? Nosotros pensamos que personal especializado, dependiendo de la herida, algunas los hacemos los adjuntos, otras las hacemos los felos, otras los residentes y otros, como se llama, otras las enfermeras y otras las pacientes en su casa. ¿Dónde debe hacerse? En cubículos de cuidado de heridas, que estos serían los más sencillos, y unas curas más grandes en estos semiquirófanos. ¿Por qué son semiquirófanos? Porque tienen luz, porque tienen una cama multiposicional. También miren en el final la computadora de a bordo, donde está la historia de cicatrización de la herida. Y el cuidado de heridas debe ser simple, barato, y en quirófano mayor solamente si es necesario. ¿Con qué frecuencia debe hacerse? Depende de las condiciones locales y sistémicas del paciente. Primero los vemos cada 2 días, cada 3 días, cada 5 días, a largo plazo cada 7 días. Estas curas son un acto médico. Quitar el parche y poner el parche es una actitud profundamente errónea, porque las piernas que se están perdiendo no están pegadas a la gente sana. Entonces, un proceso de cicatrización que dura 4 meses, 5 meses, 6 meses, 7 meses, en un paciente añoso, diabético, ese tiempo puede resultar años. Es decir, el tratamiento de la insuficiencia cardíaca que tenía puede ya no ser apropiado, el tratamiento de otras condiciones puede no ser apropiado. Entonces, siempre hay que recordar que no estamos tratando una herida, sino un paciente. A diferencia de generalmente donde ponemos nuestros buenos resultados, yo voy a poner los malos resultados que he visto. ¿Ok? ¿Qué es lo que no se debe hacer? Entonces, por ejemplo, este es un paciente que está perfectamente revascularizado por un gran, ¿cómo se llama? Intervencionista, un cardiólogo en mi país, pero el cuidado de herida fue inapropiado, el debridamiento excesivo, y entonces las bacterias ganaron acceso al tarso. Entonces ahora tenemos una osteomielitis del tarso. Es un caso de debridamiento excesivo. Aquí lo mismo. Esto era una amputación digital. El debridamiento excesivo que hizo aquí, el debridamiento excesivo rompió los arcos arriba y entonces este pie va a ser muy difícil de cicatrizar. Otra causa frecuente de problema, osteomielitis no diagnosticada, es decir, quitaron el quinto dedo, continuó la osteomielitis, pues ahora un proceso de cicatrización prolongado y ahora hay una necrosis del segundo dedo. Todo lo anterior, falta de cirugía. Entonces, generalmente estos problemas son falta de flujo, falta de cirugía. Entonces, aquí es lo mismo. En este, fíjense ustedes, una cosa que hubiera sido sencilla, este paciente no tenía problemas de cicatrización, falta de cirugía, lleva una enorme artritis séptica y a la pérdida de un pie. Entonces, errores en diagnóstico, errores en tratamiento. El tratamiento tiene que ser enfocado, balanceado, a tiempo y basado en evidencia. Entonces, miren este pie, completamente comido por una osteomielitis del tarso. Y este otro, intervenciones desbalanceadas. Este es un paciente, también una osteomielitis del tarso, una extensa pérdida tisular. Bueno, cuidado de heridas en un centro de cuidado de heridas, pero la glicemia era 280, la hemoglobina glicosilada 18%, es decir, una de las más altas que he visto en mi vida, tenía 6 gramos de hemoglobina y a pesar de que la bacteria era sensible a prácticamente cualquier cosa, se obtuvo eso. Entonces, una terapia desbalanceada, este paciente estaba recibiendo factores de crecimiento, pero no recibía antibióticos apropiados, no recibía tratamiento quirúrgico apropiado para la osteomielitis ni estaba revascularizado. ¿Cuáles son los resultados correctos? Los resultados correctos son debridamiento correcto de todos los espacios, necrectomía correcta, cuidado de heridas y finalmente pues obtenemos un pie funcional. Muchas gracias. Esto también se puede hacer quirúrgicamente, estos son bypasses, es lo mismo. Se puede revascularizar por vía endovascular o se puede revascularizar por vía abierta. Porque hacemos cada vez menos endovascular, porque un bypass distal y ese tipo de revascularizaciones pues era muy trabajoso. Pero en realidad es un asunto de enfoque, diagnóstico apropiado, tratamiento vascular apropiado, tratamiento correcto de la infección y cuidado de heridas apropiado. Muchas gracias.
Sí, bueno, agradecemos al doctor Alberti, excelente charla, excelente centro. Yo quisiera pasar con los panelistas de discusión. Tenemos al doctor Jorge Ríos, al profesor Jorge Ríos. Por favor, encienda su micrófono, doctor, si tiene un comentario para el doctor Alberti o para el doctor Incorani.
Solo felicitarlo por el trabajo que hace, me parece fabuloso. Nada más que eso, únicamente. Felicitaciones, doctor.
Gracias.
Muchas gracias, doctor Ríos. El doctor Ernesto Intriago, que es el presidente de la Panamericana. Doctor Intriago. No está el doctor Intriago por allí. Vimos a la doctora Heidi Cáceres.
Hola, hola.
Ernesto está, lo que pasa es que no tiene abierto su micrófono.
Ok,
ok, está Ernesto. Adelante, Ernesto.
Sí, sí. Muchas gracias a todos los panelistas. Excelentes sus presentaciones. Al doctor Alberti, realmente una magnífica presentación. Realmente, a veces el cuidado de herida es lo último que uno deja, pero realmente es la punta del iceberg de todo lo que se viene y realmente podemos evitar muchos fracasos, como lo comentó. Y más allá de todas las terapéuticas que fueron presentadas con muy buen criterio y muy buenos resultados, es verdad que no se debe descuidar el manejo en sí, tanto metabólico y nutricional de los pacientes. O sea que haría parte del equipo agregar también el manejo integral de estos pacientes, así como la rehabilitación. Lo felicito, doctor. interesante la propuesta que hizo.
En algún momento teníamos especialistas para eso, pero hemos tenido que sobrevivir a toda esta extraordinaria debacle que ya ustedes conocen, y entonces en eso perdimos algunos especialistas, algunos para Chile, por cierto.
Gracias.
Algunos para Chile, incluso algunos para Paraguay. Nuestro anestesiólogo cardiovascular, el mejor que he visto en mi vida, nunca falló. Nosotros operamos, como se llama, pacientes de una enorme complejidad. Se llama Víctor Vilchi, fue nuestro anestesiólogo durante años, es paraguayo. Desgraciadamente regresó para Paraguay, mucho lo lloré. Fue una de las cosas que más desarmó nuestro equipo. También nos quedamos sin especialista de enfermedades infecciosas, fue para Costa Rica. Pero bueno, más o menos hemos logrado mantenernos allí en nuestro trabajo de siempre.
Excelente.
Con esa calidad, si tiene alguno, envíenlos acá a Panamá, doctor Alberti. Bueno, acá queremos compartir con la doctora Heidi Cáceres, que la vimos por ahí. Doctora Heidi Cáceres, por favor, el micrófono. Y si tiene algún comentario corto, alguna pregunta para los doctores Alberti o el doctor Gingorani, que se ha quedado con nosotros toda la distancia. Gracias, doctor Gingorani.
¿Qué tal? Buenas noches. Muchas gracias. Para el doctor Alberti, me pareció muy interesante el nuevo concepto que está manejando. En vez de hacer multidisciplinario, hacerlo monodisciplinario, porque todos los países de Latinoamérica tenemos ese problema, ¿verdad? Es difícil encontrar varios especialistas, ¿verdad? Que cada uno haga su parte. Entonces, de repente es una alternativa interesante con los residentes que se están formando, ¿verdad? Que tengan un plan de trabajo integral, ¿verdad? Por supuesto que ha ayudado también con los demás especialistas en la medida que sea posible. Interesantísima también la charla del doctor, no me sale el apellido.
Orani.
Orani, sí, los conceptos sobre diabetes, ¿verdad? Que generalmente tenemos conceptos muy básicos, ¿verdad? No, de repente nos cuesta leer, nos cuesta manejar bien esos puntos que hay que tener en cuenta. Súper interesante también todo ello, y buenísimo que hayan estado también los residentes, estuvieron todo este tiempo, estuvieron atentos. Yo creo que les va a ser muy útil el manejo, el conocimiento de esas guías. Nada más que felicitarles a todos, excelente las charlas, aprendimos muchísimo y por eso estamos hasta esta hora, es tardísimo acá en Paraguay. Muchísimas gracias a todos.
Gracias, Heidi. El doctor Celso Aldana, no sé si está con nosotros o nos acompaña. El doctor Corbeta no lo vi. El doctor Aldana o el doctor Rafael Acosta. ¿Algún comentario de parte de ellos?
Buenas noches. Sí, por supuesto, para felicitar a los que presentaron con bastante entusiasmo y conocimiento en base a su amplia experiencia. Yo le quería hacer una pregunta al doctor con respecto al tratamiento de las heridas con presión negativa tópica, pacientes con pie diabético.
En alguna oportunidad lo intentamos. Teníamos unos dispositivos que eran unas especies de concentradores de oxígeno en miniatura que duraban 2 semanas. Pero ahí el problema se llama TCOT, tratamiento de oxígeno local. Yo no hablé de opciones avanzadas porque nosotros las hemos probado casi todas, pero al final terminamos haciendo lo mismo. Una vez un intervencionista cardíaco me dijo que así les había pasado a ellos, ¿no? Es decir, al final es el stent y todo es, entonces la criocirugía y la yo no sé qué y tal y cual terminaron siendo lo mismo. Entonces, nosotros tenemos cámara hiperbárica que ahorita no está en uso por los asuntos de COVID. Pero yo pienso que para algunos pacientes ciertamente aumentar el oxígeno local pudiera ser una opción interesante. Solamente que nosotros usamos la más tradicional, usamos una cámara hiperbárica multiplaza por cierto, construida en Venezuela por una empresa que no existe ya, pero la cámara hiperbárica fue construida localmente aquí.
Gracias, doctor. Felicitaciones por su presentación.
Gracias, doctora Aldana. El doctor Acosta está por allí. Si no está el doctor Acosta, entonces creo que vamos a empezar. El doctor Hugo Navas quiere comentarle algo acerca del doctor Alberti.
Bueno, no, nada en particular. Yo felicito al doctor Canata y toda esta iniciativa muy interesante, que no solamente se están nutriendo de ella sus residentes, sino los nuestros también, porque hemos invitado a todos los residentes que hacen angiología y que hacen cirugía vascular en Venezuela, que donde hay 3 posgrados, uno de ellos lo dirige el doctor Alberti, y bueno, felicitarlos y pendiente siempre a colaborar y participar con todos ustedes. Fuerza y que siga adelante todo esto.
Bueno, yo quisiera devolverle la batuta al organizador y gestor de todo esto, que es el doctor Víctor Canata, y no sin antes darle eternamente agradecido por permitirme participar en esto que me gusta a mí, que es la docencia, con un excelente grupo de invitados. No sé, como dice Altino, yo no sé cómo hace Víctor para reunir a esta gente, a estos médicos tan destacados. Realmente es un esfuerzo supremo tener, creo que pocos congresos lo he visto a los que he ido, tener al doctor Lowell Kapnick, tener al doctor Mills, tener al doctor Hingorani, al doctor Alberti, o sea, el doctor Moraes, o sea, eso no es fácil. Y lamentablemente pues no ha alcanzado el tiempo porque creo que quedan muchas preguntas en el aire, pero yo le doy las gracias a Víctor y que cuente con nosotros para cualquier otro evento similar. Yo creo que esto realmente nos ha permitido conocer especialistas que de otra forma no teníamos, a veces lo vemos en los congresos, pero no podemos ni siquiera acercarnos a ellos. Y aquí hemos tenido casi 3 horas para conversar con ellos. Así que, Víctor, los micrófonos son tuyos.
Lo único que quiero expresarles a todos mi agradecimiento. I just want to remind that I'm deeply thanks to everybody else and also to all my friends. Todos son mis amigos. Everybody has part of that of the webinar. Maybe one collaborate with one part, the other one did the other, y todos juntos hacemos todo. Anil colaboró con la presencia de muchísimos panelistas, el doctor Alberti, el doctor Navas, la presencia de la Panamericana a través del doctor Ernesto Intriago, todos juntos, la presencia del doctor Jorge Ríos, el doctor Taberna, todos los especialistas de alto nivel. Lo importante en todo es que lo que queremos es enseñar, lo que queremos es que la experiencia que tenemos sea compartida y sirva de base para que los pacientes que vienen más adelante conozcan el fruto del trabajo y se nutran nuestros residentes de esa experiencia que todos ustedes tienen. Así que les agradezco por todo. El grupo que tenemos se va a quedar en WhatsApp porque lo vamos a procurar de reanimar aunque sea una vez al mes, y el próximo año volveremos con una nueva serie igual. Anil, thank you very much for everything. Thanks for joining us as always. I'm very happy to have you as a friend, and you are more than aware that that everything is really difficult to do in it, but we got all those minds, all those people. They are excellent surgeons, excellent vascular surgeons, excellent phlebologists, and excellent friends too. I will just to have a quick word from you to close everything, and then we will just set up and let's go eat something before my wife call the lawyer and get the divorce from me. Okay, Anil?
Thank you very much, Victor, for putting this excellent series together. It's been a pleasure, and we look forward to more in the future. Congratulations, everybody. Great meeting.
Okay, Doctor Intriago, como presidente de la Panamericana, unas palabras, por favor. No sé si el doctor Serralde sigue todavía con nosotros.
Okay, thank
A
you.
continuación.
Thank you very much, Dr. Canata. and to all the professors invited to collaborate with the course. The Pan American Society will always be helping in the training of the resident doctor. I wish you all success. Sabes que cuentas con todos los miembros de la Panamericana. Estamos dispuestos a colaborar con todas las sociedades de este gran continente para apoyar la docencia y el conocimiento a los médicos jóvenes en formación. Gracias por invitarnos a participar.
Muchas gracias a todos. No sé si está el doctor Serralde todavía con nosotros o se retiró. Lo importante es que tenemos que seguir juntos. We have to share expertise as well as our knowledge. Thank you very much for everything. Buenas noches a todos y la noche está ganada. Cerramos estas 8 charlas espectaculares que hicimos. Fueron más de 30 horas de trabajo, así que buenas noches. Gracias por todo. Dios los bendiga. God bless us, and we will just keep us safe and healthy, just to keep sharing expertise as well as knowledge to our patients and our residents. Thank you very much for everything. Gracias por todo. Buenas noches.
Gracias, buenas noches.
Gracias por todo. Desde aquí, Mar del Plata, Argentina, el doctor Alinei les deseo unas felices fiestas. Si no nos vemos hasta entonces. Comenzaremos el año que viene quizás con otro webinar como está usted organizando, doctor Canata. Los felicito a todos de